और उसको बोल के Good evening, Edmund. Good evening to all of you. Namaskar, Sat Sri Akal, Adab, and Salam Alaikum to all of you, all of my friends, my students across the country, across the world. We at Medway here are going to present ophthalmology UltraMarathon. Okay? Not just a marathon, but UltraMarathon, which is far, far more deadly. Okay? And I'm from Delhi here, broadcasting from Delhi here. What a hot summer afternoon has just given it to even hotter and a sultry and a muggy evening. So we're all here and hope that you enjoy our show of ophthalmology here, where we're going to discuss one of the toughest but a well mixed balance of tough and simple MCQs. And guiding you through this minefield of ophthalmology is yours truly, Shashwat, your friendly neighborhood ophthalmologist, inviting you to this show today. And it's a live thing, so please ask me questions. And to all my friends, good evening. I can see Nidhi and Vipin. Good evening to all of you. So ask me questions, and we'll take your questions. So here, and this is the subject. You all know, look at those mesmerizing, hypnotizing eyes. This is the subject we're going to discuss. Look at the most famous photograph of the 20th century. Okay, when you can see the power of ophthalmology here. And so this is what we're going to discuss, ladies and gentlemen, those who have not discussed with me. And here you can see me smiling like a crocodile, inviting you to step into his jaws with a gentle smile. Okay, so this is from Medway here, and the next 2 hours, approximately we take about 2 hours, where we discuss a lot of questions which you may not have discussed anywhere else. Okay, because this is a difficult and a mix of difficult and simple questions. So here we go, and these are basically MCQ questions. So I hope you enjoy them. I hope you learn anything from this, a lot of stuff from here. So let's talk about the questions. I'm going to read this first. You read with me and we could discuss. So a 70-year-old lady presents with enophthalmos. Remember, enophthalmos means eyeballs inwards, ptosis and loss of ocular movement. Now this is a very famous triad. Remember, ophthalmology is full of triads, three things. We have enophthalmos, eyeball sunken in. Second, ptosis, lid drooping down, and loss of eye movements. Eyes are not moving. Okay, classic triad. Kindly remember, those who have not done this, you should know this. Which one of the following is the most likely diagnosis? Okay, that's a good question. Very important clinical question, asked sometimes in PG entrance also. And let's look at the choice. We have is orbital pseudotumor, cavernous hemangioma, metastasis from breast cancer, and thyroid eye disease. All very good choice, let me tell you. Is it not? Very good choice again. So enophthalmos, remember the triad, eyeball inwards, loss of ocular movements, and ptosis. So let's talk orbital pseudotumor. Incorrect. Why? Because remember, orbital pseudotumor is a kind of a tumor, but this causes exophthalmos, not enophthalmos. So this rules it out. Cavernous hemangioma again causes exophthalmos or proptosis. This is the commonest tumor of the orbit in adults. Those who might remember, commonest tumor of the orbit in adults occurs usually in young ladies between 20 to 50 years of age. So this is also ruled out because simply both of them cause exophthalmos, not enophthalmos, isn't it? And thyroid is similarly ruled out because remember, you all know thyroid is the most common cause of proptosis or exophthalmos. So that whatever remains behind, so remember, even if you do not know the direct answer, what remains behind must be the correct. We have ruled out 3, so the answer must be metastasis from breast cancer, and that's correct. That's a very important. Please remember, the clue is enophthalmos. Those who have attended my lectures or classes, you might remember I always used to say that the commonest tumor causing enophthalmos is metastasis from breast cancer. Okay, so kindly remember, this is a classic triad of CA breast metastasis. You all know that the commonest tumor in females is breast cancer. And also, second MCQ, the commonest tumor to metastasize to the orbit, is breast cancer. Okay, and third question, breast cancer paradoxically does not cause exophthalmos, it causes enophthalmos. How does it do that? Now it does that because it causes fibrosis of the extraocular muscles. So the extraocular muscles get fibrosed, they contract, and they pull the eyeball in. So remember, in older women, okay, and breast cancer is very common in the world, particularly in India. So whenever you have a lady who comes to you with enophthalmos, you always have to, your red flag should go up immediately. and we can see that. Look at that. This picture, this is enophthalmos, and older lady. Look at the ptosis and the enophthalmos. Okay, obviously you cannot see the restricted ocular movements because this is not a video. So the ptosis and the enophthalmos in an elderly female, your red flag goes up immediately that it should be breast cancer. You see, because these are unfortunately almost 30 to 40% of cases, they come to us with CA breast metastasis, and these 30 to 40% cases are not aware that they have a primary breast cancer. They are not aware of the lump in the breast. So that is why you see we always insist that in India at least every female should undergo a mammogram after 40. Once annually, every female should undergo after 40. Okay, so this is a very important MCQ. Kindly remember. The clue is that the enophthalmos. Of course, for those of you who know the classic triad of breast cancer, that's wonderful, but it's enophthalmos. So I hope we've got this. Even if you did not know this, you could have got it by eliminating the other cause of exophthalmos. And let me see. Yes, I am the boss. That's correct, Ankit Kapoor. Thank you very much. No thyroid. Somebody has answered thyroid. No, it's incorrect. Thyroid will have caused exophthalmos. Very well. Never mind if you got this incorrect. You're learning new stuff, isn't it? Let's look at the next question. Next question we have. Okay, this is a much easier question, and I hope you all get this. A landmark randomized control trial, RCT, as you all know, on facial cleanliness in Tanzania reduced a certain disease by almost 35%. My God, incredible. A disease reduced by 1/3. And what disease was it? Just by facial cleanliness, by cleaning your face. And that should be easily answered by all eligible. Let's look at that. It's gonococcal conjunctivitis, could be trachoma, could it be spring catarrh, or could it be ophthalmic unitorum. Okay, so each of them very good choice. Ophthalmic unitorum, children, spring catarrh, trachoma, and gonococcal conjunctivitis. Remember facial cleanliness, and I'm sure all of you have got this right. It is going to be trachoma. Remember the famous SAFE strategy? SAFE, SAFE strategy of trachoma. Surgery, S for surgery, which is trichitic cilia, A for antibiotics, remember azithromycin, F for face washing with water, E for environmental sanitation. Okay, so this is the famous SAFE strategy, and even if you did not know about this RCT, you would know that it is in trachoma. Isn't it? The answer is trachoma, and this is a very famous trial actually. You know, RCT, as you know, you must have done in PSM. And did you know, let me tell you one important trivia. The first RCT, the first ever RCT, randomized control trial, was what? It was for streptomycin. I think it was in the 50s or 60s, I'm not very sure. The first ever RCT was conducted for testing the streptomycin, okay, for tuberculosis. Very well, that's just a trivia here and there. Next question. So this is the famous picture from the same trial, you know. So these children were encouraged to wash their faces, you know, because they would never wash their faces. The sticky discharge, they would rub their eyes and they would transmit trachoma. So this is how it works. And if you have any questions, let me see. Very good. Somebody's got, Nidhi, you've got this correct. Surgery, antibiotics, facial hygiene. Excellent. Trachoma is the right answer. Awesome. I thought you would get all of them. Very good, my friends. Next question. A 25-year-old lady with a 2-month history of persistent abdominal cramps. So abdominal cramps, when bloody diarrhea, so blood in stools, presents with a red painful eye. What is the diagnosis? And remember, what is the connection between bloody diarrhea or blood in the stools with a red eye? So there are two reds here, the stools and the eye. Well, what could that be? Let's look at the connection. Could it be bacal conjunctivitis? Could be angle closure glaucoma? Could be anti-uveitis or scleritis. Okay, so I hope you can all do that, because this is not a difficult question, but it can be worked out. And so bloody diarrhea with a red painful eye, so connection with stools in the eye, and I'm sure most of you got this right. It is indeed anterior uveitis. Remember anterior uveitis? Remember the famous HLA-B27? We had this particular group of HLA-B27 related spondyloarthropathies, these are spine in the joints, and the connection between abdominal cramps and bloody diarrhea is ulcerative colitis. One of the HLA-B27s is ulcerative colitis. Remember the IBDs, inflammatory bowel disorder, so ulcerative colitis, or you can have the second one is Crohn's disease, both of them. So both of them are parts of the IBD, and they can both cause anti-uveitis. So, this is the HLA-B 27 question which you've got, ulcerative colitis. This is, the hint is that again the younger women, you remember that these are, IBD is usually an autoimmune disorder, and autoimmune disorder is always very common in females. You know why? Autoimmune disorder are much more common in females, like rheumatoid arthritis, like this. Why more in females? Because the females have a very powerful immune system. You should all remember, females have a very powerful immune system, and that is why you ladies, many of you ladies know that when you get a cough and a cold, you get it over it in 3 days or 4 days maybe, whereas your boyfriends and your husbands, they keep coughing away for a month, is it not? So, the females have a very powerful immune system, much more powerful than males, and when this powerful autoimmune system turns against itself, so then that is why autoimmune disorders are mostly common in females. Okay, so this is answer anti-uveitis, and look at that. This is anti-uveitis. You can see the circumciliary congestion, the anti-uveitis caused by ulcerative colitis, with the irregular pupil, which is called the festooned pupil, and the hypopyon, which tells you that it's a fairly severe uveitis. Remember, hypopyon is seen in severe uveitis. And you have any questions here? Anybody? Uveitis, absolutely right. We've got this correct. We've got somebody's got this right. Okay, this is uveitis indeed. Good. So you're all doing very well. And those who haven't done well, don't worry. You will all do well. Let's look at that. Now that's more. This is a difficult question, slightly more difficult, because from PG entrance exams, 15-year-old girl is intolerant of her high cylindrical power, and many of you are that. Well, cylindrical glasses are difficult to wear. They may often cause a lot of dizziness, disorientation, and children and a lot of adults are intolerant of a high cylindrical power. So, she suffers from severe allergic conjunctivitis. That is another problem. So, what is the best correction for her? Okay, because she can't wear her high cylindrical glasses. So, what have the options? We have contact lenses as one option, okay, spherical equivalent glasses, another option, LASIK, which is laser assisted in situ keratomileusis, which is refractive surgery, the most popular one, which many of you are waiting for. The minute you pass your exams, you are going to get this done, isn't it? And PRK, photorefractive keratectomy, which is also another kind of refractive correction. So, let us now start ruling it out. Okay, so let us rule out. See, it cannot be contact lenses because she is always some severe allergic conjunctivitis. You cannot give contact lenses. They will rub the eyes all the time and throw the lenses out. Is it not? They push the lenses out. And PRK and LASIK is ruled out. Why? Remember, look at the age 15. Remember, refractive surgery, the earliest age is 18. You cannot do it less than 18, and in fact, I prefer to do it after 21 only. Okay. So, remember the limit, the lower limit of refractive surgery, any kind of refractive surgery is 18 years of age. So, this is a 15-year-old teen, and she cannot have refractive surgery because the power is still changing, and we cannot do refractive surgery for a person whose power is keeping changing. So, we have ruled out lenses, we ruled out the refractive surgery like LASIK and PRK. What left behind is spherical equivalent glass. Now, what is that exactly? So, let me talk about spherical. See, this happens to people who often have a high cylinder. High cylinder can be from as much as -3, -3.5, -4. Some of you can be very intolerant. So, what happens when you have a very cylindrical power? So, we give the glasses which is something called spherical equivalent. Okay, what is that? It means a sphere which is equal to the cylinder. So, this is a spherical equivalent. So, when you have a high cylindrical glasses, we give a sphere because they cannot tolerate the cylinder. We give it a sphere. But you see, it cannot be the same thing as the cylinder. Suppose any of you is wearing a -6 diopter cylinder, okay, say at 90 degree. Now, this is a high cylinder, and many of you will not be able to tolerate the high cylinder simply because it's very high, and you may have dizziness and you may have disorientation. So, what we do, since you cannot wear a high cylinder, but you can wear a high sphere, because spheres are not so difficult to tolerate. Okay. So, but you can't give her a -6 diopter sphere, okay, because this is completely different from this, is it not? You cannot replace the entire cylinder with a sphere, because if you do that, the vision would drop down to very poor vision, 660. With this, there would be 6/6. With this, there will be 6/60 because this is not the correct prescription. So, what we do, we cannot give a sphere just to replace cylinder. What we give is a spherocylinder. That means a sphere which is equal to this cylinder, and that is not just by replacing the cylinder with the sphere. So, look at that. So, there is a formula here which you should know, we call spherical, the SE. This says cylinder by 2 plus sphere. The formula is this, cylinder by 2 plus sphere. So, to give the same example, suppose you have a -6 diopter cylinder at 180 degree. Okay. Now, this is, let's say, this is a high cylinder. So, you are intolerant to this and you are having dizziness and disorientation here. So, what we do this one, cylinder by 2. So, cylinder is minus 6 by 2 plus sphere. Okay. Sphere, there is no sphere here. So, this is becomes 0. So, minus 6 by 2 is minus 3 diopter cylinder, minus 3 diopter. This is not cylinder here because it is sphere and this is 0 here. So, this is minus 3. So, remember, if you have a minus 6 diopter cylinder at 180 degree, I just give minus 3 diopter sphere. This is the spherical equivalent of this particular prescription. So, she will not be able to tolerate this, but she will be able to tolerate the sphere, because just a pure sphere minus 3 diopters, the vision will be very good. The vision will not be 6 by 6, there will be 6 by 9. Sometimes the vision is one line lesser, but the vision is one line lesser, but it is still very good. So, this she will have 6 by 6, but with dizziness and disorientation. She will have 6 by 9 with this and they will be very happy. Let us take another example. You should know this concept of spherical equivalent, which we do very commonly, and sometimes a lot of villages, because the cylinders are high and they are more expensive. So, we give these glasses and these people do very well. Okay. Let us look at that. So, supposing I take another example, say you have an example of a minus 4 diopter sphere with a minus 6 cylinder, let us say, at 90 degree. Okay. So, again it is a high cylinder. So, you have this an example of a compound myopic astigmatism. Those of you who read refractive error, you might remember, we have 2 minus signs. So, it is a compound myopic astigmatism. So, again as you see, it is a minus 6 cylinder and the patient cannot tolerate this prescription. It says, doctor, I am getting dizzy with this, I am getting a chakkar with this. So, we do spherical equivalent of this, which means that we replace this prescription, which is a compound myopic, with a spherical prescription, but the spherical will be equivalent to this one. So, remember, we cannot just give minus 6 sphere, okay, because, or we cannot just replace the minus 6 cylinder, we cannot just give minus 4 diopter sphere. If we give this, because this is incorrect prescription, the vision will drop to 6 by 60. So, we do not give this only. So, what we do, cylinder by 2 plus sphere. Cylinder is minus 6 by 2, what is that? That is minus 3, and plus sphere. Remember, it is an algebraic summation. So, plus the sphere is minus 4. So, if it is 4, so minus 3 and minus 4. So, it is a summation. So, minus 3 and minus 4 is minus 7, and this is the correct power. We will give a minus 7 diopter sphere. It is a spherical equivalent. So, this particular prescription, remember, minus 7 diopter sphere is equal to this particular prescription in spherical form. With this, the patient will see very good 6 by 9. On the other hand, if you give just minus 4, then the patient will only have 6 by 60, very poor vision. But if you give a spherical equivalent, then the vision becomes pretty good, may not be as good as 6 by 6, because you are after all replacing a cylinder with a sphere, but it's still pretty good, 6 by 9. Okay. So, this is, my friends, you should remember this. This is a very important calculation and you should all remember this. I will do one more just so that you remember this. It's very important. Okay. And like us, we'll take plus 2 diopter sphere with a plus 8 cylinder at 180, let us say. Okay. Now, again you see this is a very high cylinder. So, patient is not going to tolerate this. So, you want to give them glasses. So, if you want to just give glasses, they will tolerate a sphere. But if you give only plus 2 diopter sphere, this is not going to work, because you have removed this plus diopter cylinder 8, the vision would be very poor. So, we do not give just the sphere, we give a spherical equivalent. Remember, cylinder by 2, cylinder by 2 is plus 8 divided by 2 is what? Is plus 4. Okay, so, plus 4. So, cylinder by 2 plus sphere, the sphere is what? Plus 2. So, 4 plus 4 plus 2 is plus 6 diopter sphere. So, now we can prescribe this. See, it is a pure sphere, but this is the spherical equivalent of this particular prescription, and the patient will not tolerate this, but the patient will tolerate a sphere very nicely. This will give her or him 6 by 9 vision. It may not give you 6, but one line loss might be there, but at least they are tolerating this and they have very good vision, they are very happy with that. Okay. So, please remember that this is how the answer to this particular question here was this. The answer to this particular question is spherical equivalent glasses. So, kindly remember this kind of thing. Many times we do this, people with high cylinders, we prefer spherical equivalent because they cannot have refractive surgery, they are too young. Contact lenses, no, because of severe allergic conjunctivitis. I hope you've got this. If you've got any questions, and leaning forward to look see any questions. Okay, very good. Next question. Next question, ladies and gentlemen, and here let me erase this. Following a blow to the eye, with a tennis ball, a child develops nausea, bradycardia, and syncope. Look at that. Now, this is an interesting question, and you should understand this. Following a blow to the eye with a tennis ball, a child develops nausea, about to vomit, bradycardia, very serious because the heart rate is coming down, it may become very, very low, and syncope, he collapses. Okay. This is a sign of what? We remember this classic trial, and I think that some of you should be able to remember this if you've done your medicine, surgery, and anesthesia well. A sign of orbital fracture, a rosette cataract. Remember, after all, you have a blow, you can have a rosette cataract, you can have ocular cardiac reflex, and oculodigital sign. Okay, now what is this? The answer here, I hope you got this, is the oculocardiac reflex. Remember, when you rub your eye, when you rub your eye, particularly hard as you rub your iris or you are doing surgery, so you stimulate the eyeball. And you stimulate the eyeball, there is the fifth nerve. Remember the ophthalmic branch with the fifth nerve? So that occurs afferent, and this goes and stimulates the vagus, the 10th nerve. So the afferent is the ophthalmic branch of the trigeminal, the 5th cranial nerve, and stimulates the vagus, the 10th cranial nerve. So this vagus, it works on the heart, causing bradycardia, syncope, and nausea. And this may happen in a child with a blow to the eye, or sometimes during surgery. This is a very famous reflex called the ocular cardiac reflex, because the bradycardia may be so intense that the patient may actually collapse and the syncope is there. So this anything when you push your eyeball like this, when you rub your eye vigorous, particularly with both hands, a thing which should not be done, it may stimulate the ocular cardiac reflex. Remember, it's dangerous, patient may fall, and in some cases may even die, because the bradycardia sometimes is so severe, the heart rate falls to less than 20 times a minute, patient may expire. Okay. So this, remember, very important. So kindly, all those of you, do not press your eyeball very hard, particularly both hands, you should not do that. It may stimulate the ocular cardiac reflex. Okay. And this happens sometimes in children with a blowout fracture, okay, when they get hit. So this is a very important clinical scenario, often in emergencies, where the child is brought collapsing and have very weak pulse rate. Okay. So this is the famous ocular cardiac reflex. Remember the afferent and the efferent. The afferent is the 5th nerve, which is the trigeminal, the ophthalmic branch, and the efferent is the 10th nerve, which is the vagus, which is actually causing the bradycardia. And the vagus, the 10th nerve, remember the vagabond nerve, the longest intracranial nerve, the longest cranial nerve, not intracranial, sorry, the longest cranial nerve. No, the vagus nerve, the vagabond nerve, goes everywhere like a vagabond. Very well. What next? So this is a lot of new stuff coming up for you also. And all of the following signs are useful in differentiating papilledema from optic neuritis. Okay. So you want to differentiate papilledema from optic neuritis, except, so there is one sign which is not able to differentiate, the rest of them are able to differentiate. So let's look at that. Optic disc edema, loss of spontaneous venous pulsations, presence of Patton's lines, and peripapillary hemorrhages. And this is not that difficult a question as might be thought of you. No, it's not that difficult. So basically, you want to differentiate papilledema, which is what? Disc edema due to raised intracranial tension, from disc edema due to optic neuritis. So what is not helpful? No, except. So you can see optic edema is immediately the answer, because it occurs in both optic neuritis as well as papilledema. So it is not able to differentiate. Disc edema cannot differentiate because they are found in both papilledema as optic neuritis, isn't it? So that is the answer we are looking at, except. But the rest of them can. How? Let's look at that. A loss of spontaneous venous pulse. Remember that there are only two veins in the body which pulsate. Remember, always the arteries pulsate. There are only two veins which pulsate. What is that? One is the jugular pulsating, the vein, remember, and second is the central venous pulsations on the optic disc. No other vein pulsates in the body, okay? And they have different reasons why they are pulsating. The jugular pulse is pulsating, jugular vein, because of the transmit pulsation of the carotid artery. That is pulsating because of the difference between intracranial pressure and intraocular pressure, okay? So what happens in papilledema? There is spontaneous venous pulsation, they are lost, but not in optic neuritis. So if you have disc edema where there are no pulsations, it means that it is papilledema. If you have disc edema where it's pulsating, it means optic neuritis. Okay, so that is differentiating. So all of them are differentiating except this one. Presence of pattern lines, this, yes, this also differentiates. What is that? Pattern lines are basically lines around the optic disc, okay, because in papillary edema, there is so much edema that this edema, it creates folds in the surrounding optic disc, okay. It's like, suppose that because the disc is elevated so much, no, it's full of edema, it's elevated so much, so it pulls up on the surrounding retina, and the retina, have this circumferential folds around the disc, which is called the pattern lines. So this again tells us this papillary edema, it is not seen in optic neuritis. And peripapillary hemorrhages are hemorrhages all around the optic disc. Again, these are signs, as you can see, look at that, you can see the disc edema. How do we know this is a disc edema? Because there is blurring of the disc margins, there is blurring of the disc margins. And look at the hemorrhages here. Now, this is typically seen in papillary edema, raised diastole causing disc edema. It is not seen in optic neuritis. So, as you see, all these three, the peripapillary hemorrhages, the pattern lines, and disc and Wells palsy, they are all found in papillary edema. Okay, none of them are found in optic neuritis. So they all differentiate between papillary edema and optic neuritis, except disc edema, which is not differentiating because it is seen in both of them, and that is what the question is. Which of them? All of them except. And the answer therefore is optic disc edema. And have you all got this correct? I hope many of you are answering this. Let's hope you're getting this. We've got a if you have any, please write to me and we'll discuss this. This answer is correct. Okay. As I said, it looks difficult, but it's not really. Okay. Very well. What next? We have this is an important question because this is one of the numerical questions that we like to ask you. What percentage of a topically applied drug penetrates to the aqueous humor? That's interesting because when you put drops, so how much is actually penetrating through the cornea into the anterior chamber and how much is systemically absorbed? Is not that's an interesting thing. Pharmacology as well as ophthalmology. Let's look at the choices. 5% only, dear me, only 5%, 100%, 30 to 40%, reasonable, and it doesn't penetrate at all. And let's see how many of you get this right. What percentage of an eye drop penetrates to the through the cornea and into the anterior chamber, into the aqueous humor? Ladies and gentlemen, it's only 5%, that's all. Only 5 to 10% of the eye drop. This is a thing that I always tell you in my classes, that every eye drop that you put in the eye, most of it is not absorbed into the eye. Okay, so only 5 to 10%, that's it. 5% is the correct figure. The rest of it gets absorbed to systemic circulation via the nasolacrimal duct. So all topical drugs, all eye drops have systemic side effects. So kindly remember, be careful, be watchful of whatever you put in your eye. Okay, and you can see this is the correct technique for putting that up. She is demonstrating a very correct technique. You pull the lower lid down, you look up and put the drop in the lower fornix like this. Okay, so with one eye, with one finger you pull the lid down, create a pocket, and into this pocket you put the drop. One drop, remember, only one drop. When you put eye drops, kindly remember, there is not enough volume. The drop size is of a standard eye drop is approximately 50 microliters. The conjunctival sac has a volume of 40 microliters. So even one drop is actually excessive. So if you put two drops, it's a total waste of medication. Okay, so you have to just put one drop, and the correct technique is this: put a drop, close your eyes for a couple of minutes, allow it to absorb, and then you go on. Okay, so this is the correct technique for putting. Remember, always those of you put drops in your eyes, one drop, close your eyes for 2 minutes, and then open it. Okay, and the next drop comes, if you have to put another drop, at least 10 to 15 minutes gap. Okay, you do not put it before that. You have to wait for 10 to 15 minutes because there's not enough space in the fornix to accommodate two different drops. You have to wait for 10 minutes before the next comes on. You can wait for a couple of hours also, that is not important, but the minimum gap between any two drops should be about 10 minutes. Okay, so these are very important practical points when you explain to the patient how to put the eye drop. Good. So I hope most of you got this correct because this is a very important MCQ which they love to ask you. What else? Then what else is the next question is on examination of the retina. This is one of my favorite questions which I often ask, and you may have found this in many of my classes. On examination of the retina, a student notes peculiar stripes like that seen in a tiger, like the Royal Bengal tiger, and so she notes down the finding as a tigroid fundus. A tigroid fundus because of the stripes seen in a Royal Bengal tiger. And in what condition is it seen? And I hope that most of you got this right. I hope that most of you got this right. I really hope so. Let's look at the choices, but if you don't, let's get the choices. Diabetic retinopathy, hypertensive retinopathy, myopia, and hypermetropia. And how many have got this right? I hope you've all got this right. The answer, ladies and gentlemen, is myopia. In high myopia particularly, it is not diabetic retinopathy. They have other findings, hypertensive retinopathy. So you get plenty of soft exudates, flame-shaped hemorrhages in hypertensive retinopathy. Diabetic retinopathy, plenty of findings. You have irmas, you have microaneurysms, you have beading, you have dot and blots, you have soft, hard exudates, soft exudates, anything, but not a trichoroid fundus. And hypermetropia, you don't have a trichoroid fundus. You have something called a watered silk fundus. Old question. It shines like a silk, sometimes called short silk or watered silk, like you put water over silk. That's hypermetropia. But the MCQ that interests us, the famous trichoroid fundus, is in myopia. Look at that. Can you see the tiger-like stripes of His Majesty the Royal Bengal tiger? Okay. But why is it seen? So, see, what are these stripes here? See, these stripes that you see, the dark stripes that you see, are actually the choroidal blood vessels. The choroidal blood vessels, remember, are flat and ribbon-like. These are the retinal vessels. The vessels that you see here, these are retinal blood vessels. They look like that. But the dark areas of the stripes actually are the choroidal blood vessels, which are flat. And normally you don't see them. Why? Because the retina is on top of the choroid, so you cannot see through the retina. But in high myopia, as the eyeball, you know that the main cause of myopia is axial myopia, not the eyeball is longer. As the eyeball becomes longer, the retina stretches. As the retina stretches, it becomes thinner. So, through the thinned retina, you can see the choroidal vessels. The choroidal vessels become visible only because of the stretching of the retina and thinning of the retina. So, that is why you are able to see the stripes here, which resemble that of a tiger. And so, this lady was very correct when she wrote a tigeroid fundus. It is indeed called the tigeroid fundus, as you can see here. When tigeroid fundus is a very famous MCQ seen in high myopic patients. And you all remember, I hope you all remember that high myopia is anything more than -6. Anybody wearing more than -6, we call them -7, -8, -12, we call them high myopia. Okay. So, because of the thinning of the retina, because of the extending eyeball, the retina becomes thin, and through the thinned out retina, we can see the choroidal vessels, which are what exactly, which is called as the, so these vessels are tigeroid, like the stripes of a tiger. Okay. Very interesting, and I hope most of you got this right. We've got any comments here, ladies and gentlemen? Yes, we have got some myopic. Nidhi is answering very well, Nidhi. All the best. You're doing very well. Next question. Following a chemical burn, now that's important. Chemical burns are important emergencies for us. You know that, no? Following a chemical burn, a 30-year-old pharmacist presents with a limbal injury. So, pharmacology students, pharmacists often get, while mixing drugs, they get burns and presents with a limbal injury. And so, limbus, remember, limbal means limbus, and that's very dangerous. You know why? Because limbus is a junction between the cornea and the sclera. And why is so important? Because all the corneal stem cells, remember, stem cells means all the corneal stem cells means they are the precursor cells from where the epithelium arises. So, if the limbus gets damaged, so the stem cells get damaged. If the stem cells get damaged, then the corneal epithelium cannot heal. It's not, because all the epithelial cells of the cornea, they come from the stem cells. So, all of them are signs of limbal stem cell deficiency. So, remember when you have limbal stem cell deficiency, the stem cells lie in the limbus. That's another MCQ. Where do the stem cells lie of the cornea? In the limbus. So, whenever we have limbal injury, we are in danger of developing stem cell deficiency. So, what are the signs of this limbal stem cell deficiency? Let's take a look at that. Stromal scarring, 1. Corneal epithelial haze, which makes sense. Glaucoma and neovascularization. And see, remember what I told you again. So, then the limbus of the limbus, which lies between the cornea and the sclera, is the site of the stem cells. So, kindly remember, this can also be asked as MCQ. What is the site of the stem cells of the cornea? And they lie in the limbus. Okay. So, the limbus is damaged, and there are many other ways of damaging limbus. One of the most common is a chemical injury. Okay. What could be others? Well, you could have a prolonged contact lens wear, because the limbus, the contact lens edge, it rests on the limbus. Okay. So, prolonged contact lens wear can damage the limbus. Another could be vernal keratoconjunctivitis, damage to the sclera and the limbus around it. Okay. So multiple occurs. So, what is the answer? Stromal scarring? Yes, it's definitely possible. That is one of the most common. The corneal stroma develops a scar. Epithelial haze? Absolutely, because epithelium does not grow back at all, because the stem cells itself are damaged. Glaucoma, unlikely. Glaucoma is not a side effect of limbal stem cell injury. And neovascular, yes, definitely neovascularization, because remember the cornea is avascular and the blood vessels will move into the cornea. Look at that terrible side. Look at the typical limbus. You can see the limbus. This is the limbus. It's become pale. The normal limbus is not like this. It's a limbal injury. The stem cell injury has occurred. So you can see neovascularization. Look at the corneal haze, the stromal scarring. All these are signs of limbal stem cell injury. Okay, a very important site of the limbus because it sites the stem cells, locates the stem cells. So the answer here, ladies and gentlemen, I hope you got this. If not, don't worry, it's a very important question. Glaucoma is not a sign of limbal stem cell injury. Okay, I hope many have got this correct. Have you? You've got an answer here. Wow, I've got that. And again, dear me, it's Nidhi only who's answered glaucoma. Excellent, Nidhi, you're doing very well. Very well. So we have, this is a very important question. Right, what next? So don't lose heart, those who are not able to answer, please remember that you're gaining something new. It's not about how many you've answered, it's about how much you learn in a session, isn't it? So a 12-year-old boy, so let's look at that. We have this, a 12-year-old boy on long-term treatment for spring catarrh develops blurring of vision. Dear me, why should that be? He's on treatment for spring catarrh. So why should he develop blurring of vision? What is the probable cause? I like this question because this is actually happens to us very commonly. Let's look. Retinopathy of prematurity, refractive error, posterior subcapsular cataracts, and optic neuritis. Now take a look at that, ladies and gentlemen, and tell me if you got this. If you've got ROP, refractive error, posterior subcapsular cataracts, optic neuritis. Remember, long-term treatment for spring-term catarrh. See if you can work it out for me, my friends. See, try that, and the answer is, now I've given enough time, could be ROP, definitely not. Why would a child develop loss of vision after 12 years? ROP occurs if you have to lose vision. Remember ROP, they lose vision immediately, within a few months of being born. Okay, it's not too much, but ROP, they're very premature kids. Refractive error, why at 12-year-old? Refractive error comes at 6, 7, 8 years of age, and why should? Because of long-term treatment or VKC. Optic neuritis, unlike 12-year-old children do not develop optic neuritis at all. The answer, ladies and gentlemen, is a posterior subcapsular cataracts. And can you tell me why? Why should, what is the long term? Because remember, a posterior subcapsular cataract which you see here is because of steroid induced cataracts, is it not? Remember, in spring catarrh, they always itching their eyes, is it not? And the treatment, you begin with mast cell stabilizers, but usually because these are very, very powerful allergy, so we have to sometimes give them steroids, okay? Particularly in the south of India, where already they're hot summers and these kids suffer terribly. They're always rubbing, their eyes, blepharospasm, tightly shut lids, often called morning misery, then another name for vernal catarrh or spring catarrh is called morning misery. Not because they have to get up in the morning and attend my lectures, but because as soon as they get up, they have the strong light causes photophobia and blepharospasm, okay? So they too give such patients some relief. Sometimes we give them steroids, very limited steroids, topical steroids, because topical steroids will treat the allergy. But because these patients are supposed to stop the steroids within a week or so, but unfortunately this is India where they do not follow, and they give such dramatic relief from the terrific itching that they keep on putting these steroids and they land up with a cataract and glaucoma. So remember, this is a very interesting question, particularly because it's very commonly seen practically also. So that is why we must not give steroids to patients whom we think will not follow up with us. Okay, we only give it to patients whom we think will follow up, or they'll stop the steroid after some time if they don't follow up. Yes, this is a very important question. I hope you've all got that. Okay, some of you seem to have got that. Very well. What's the next question, gentlemen? I hope you are all doing well. And even don't feel bad if you haven't been done with. Don't feel bad again. I told you, it is what you're learning, what's more important. Okay. So next thing is, which of the following symptom is not? Now remember, again, all of them fall except. So you have to read the questions before. Here I must insist that whenever you read a question in the MCQ, you must read it 2 times, not 1, 2 ideally. And in fact, ideally would be 3, I would say. Sometimes you don't have the time, of course, because these are small points which you miss out. Which of them is not? All of them are except. Which is the most likely? Which is the least likely? Okay, you have to read the language. The English language is a difficult language, and you have to be careful. Least likely, most likely, unlikely, Except, all except. We have to be careful what we are being asked. You see, the examiner is not interested in what you know. He only wants to know whether you can answer his question. He doesn't know what you know. He doesn't need to know. He doesn't want to know. He needs his answer to it. And that's why I have to read the question very carefully. Okay? Is not commonly associated with myasthenia gravis. Very important. Myasthenia gravis is one of the favorite questions of examiners. Diplopia, that's double vision, fatigable ptosis, resting tremor, and muscle weakness. And I think all of you should be able to get this. You've done your ophtha and medicine. You revised well. Diplopia is it? Yes, they'll have diplopia. Definitely they have double vision. Because why double vision? Because remember, all these extraocular muscles, superior rectus and medial rectus particularly, is myasthenia, so they're not able to contract. So not able to contract, so they can't keep the eyes together. So eyes are often moving here and there, and they'll have double vision. Diplopia is the second most common presentation, presenting symptom of myasthenia. Fatigable ptosis, what does that mean? It means ptosis which increases with exhaustion and tiredness. That is why, that's correct, we call this fatigable, because as you get more and more tired, the ptosis increases. You know why? Because remember, the basic pathology of myasthenia is that the acetylcholine receptors get blocked, isn't it? So every time muscle contracts, okay, remember, in a normal neuromuscular junction physiology, you all know that every time a neuromuscular junction contracts, so the second time it contracts, the amount of acetylcholine is released is less, So as it contracts more and more and more, each time the amount of acetylcholine released becomes a little less. Now in this case, what happens? Already there is blockade of the receptors. But particularly, so right from the morning itself they are tired, but as you contract more and more, so less and less acetylcholine is being released each time, and it's whatever is released is the receptors already blocked, so it worsens with the fatigue. So at the end of the day, the ptosis worsens. So we call it fluctuating ptosis and fatigable ptosis. Both are terms. Fluctuating and fatigable ptosis are the sign of myasthenia. Okay, so ptosis is the number one presentation because the first muscle to get damaged in myasthenia is the levator palpebrae superioris, LPS. So ptosis and diplopia. So they are present in myasthenia, but that's what we don't want. We said which of them is not. Resting tremor, muscle weakness, of course, is the sign, okay, of myasthenia because of the blockade of the receptors. So the muscle, there is no transmission of the neuromuscular impulse, so there is no contraction, so muscle weakness which worsens with exhaustion. But resting tremor, as you all know, and I think you should answer this, is not seen in myasthenia. Resting tremor is a sign of Parkinsonism, is it not? Parkinsonism, resting tremor, is it not? So this is a very important sign of Parkinsonism. You have another tremor called intentional tremor, where when the patient has no tremor at rest, when he reaches out for something, when he's acting out something, then the tremor begins. That's intentional tremor, which could be sign of anxiety, it could be thyrotoxicosis, so many other things. And particularly, it can be a sign of multiple sclerosis, intentional tremor, multiple sclerosis, anxiety, thyrotoxicosis, but resting tremor is Parkinson's. So the answer is here. I hope you've all got this. And how many answers have we got this? Let me see if you're getting this. Somebody has got this VKC rise. Yes, absolutely. Again, my God, Nidhi again doing so well. Nidhi is doing very well again. We've got resting tremor as Parkinson's. Excellent. I'm so glad you people are doing so well. And here you see classic myasthenia. You see the picture. Look at the ptosis here. And this can be unilateral. It can be bilateral. No, they can be bilateral. And you see this second picture. Why? What has happened? We have given injected edrophonium. Edrophonium acts within seconds and immediately the lid opens. You can see if you by the lower lid, the expression a little gloomy, a little sad. Why? Because of the muscle are not contracted. So these patients often look facially very sad or upset or depressed. Okay, like many of you are depressed when you're listening to me. And so immediately as you inject edrophonium, okay, immediately it opens suddenly in a few seconds. This blockade is reversed and immediately the muscles are on. You can see the patient looks much more alive and more active after injecting edrophonium. Okay, the tensilon test, as you can see it here. Very well. Next question. All of them are true about HSV keratitis, herpes simplex virus causing keratitis, except again. So see, except these are nowadays the norm nowadays. Clinical questions have except. So what is not true? We need to find out. Dendritic ulcer is characteristic of HSV keratitis. Choice number 2, loss of concentrations are seen, 3 steroids are indicated, and risk factors for reactivation of herpes simply include stress, sunlight, fever, trauma, etc., etc. Okay, so remember, Herpes simplex keratitis, let's talk about from the top to bottom or bottom top. Remember, herpes simplex keratitis mostly is reactivated. Primary herpes is unlikely, is not very common. Herpes keratitis, primary herpes is unlikely. Most of them are reactivated, which means that you already have herpes infection, like you have a viral fever, cold, cough, sore throat, etc. Okay, and that gets reactivated. So, this is called reactivation, and that is the much more common cause of HSV keratitis, and that's correct. Remember, includes stress, yes, that's correct. Sunlight, exposure to sun, yes. Fever, trauma, this is a correct answer. These are all the risk factors of reactivating the herpes. Okay. Then dendritic ulcer, we all know dendritic ulcer is characteristic, of course, like the branches of a tree, and loss of consciousness are also seen, herpes simplex. So, what is not seen, and that is the answer, except remember, what is not seen, the steroids are not indicated, absolutely. Remember, steroids are not indicated at all. Remember, in any ulcer, in any corneal ulcer, steroids are contraindicated, particularly fungal ulcer. Remember, giving steroids to a fungal ulcer is tantamount to putting ghee on a sacrificial fire. Okay. So, remember, steroids are contraindicated in all ulcers, but particularly fungal and followed by herpes. It will rapidly, spread like wildfire, and that is the answer. So, remember the classic dendritic ulcer. Kindly remember all the 4 shapes of ulcer. Bacterial ulcers are what? Ulcer serpens, particularly they move like a snake, which is a streptococcal ulcer. Remember, acanthem ulcers are ring shaped. Okay. Remember, these are dendritic, like a branch of a tree, and fungal ulcers are, they have satellite lesions, and fungal ulcers are fluffy finger-like projections, like digging fingers into the surrounding stroma, is it not? So, these shapes are important here, and the answer judgment is here. The steroid should not be indicated in a viral ulcer. Herpes ulcer, and let me see how many you got this correct. And good. So, many of you have got this right. Steroids contraindicated, many of you got this right. Absolutely correct. You are all doing very well. I am so proud of you. So, kindly remember the dendritic keratitis. Okay. What else? Next question. A 25-year-old lady. Okay. Remember, I am going a little fast because I do not want you to waste your time here. I said it was short and sweet. So, we do a quick rapid fire session so that you get a lot of facts in a couple of hours, and that should be fine. A 25-year-old lady wearing contact lenses for the last 7 years develops redness, irritation, lacrimation, and foreign bodies. And remember, it could be any of you. Many of you are 25-year-old ladies, and you do wear contact lenses, is not? So, you develop after 7 years redness, irritation, lacrimation, and foreign body sensation. The visual acuity is still 6/6, thankfully, and there is no fluorescein staining of the cornea. That's an important fact. We'll discuss why. What is the most likely diagnosis? Okay, and I'm thinking that many of you should have got this immediately. Bacterial corneal ulcer, very dangerous. Keratoconjunctivitis sicca, dry eyes, acute anti-uveitis, and GPC, giant papillary conjunctivitis. Remember, bacterial corneal ulcer, one of the most dreaded complications of contact lens wear. You all know the most common bacteria to attack, or most common microbial organism to attack a contact lens wear is Pseudomonas. You all know this is deadly. So, this is Pseudomonas. Number 1 is Pseudomonas, number 2 is Acanthamoeba. But this is not a bacterial ulcer. You tell me why. Well, first remember, what is the most important symptom of any ulcer is the pain. Remember, there is no pain mentioned. There is redness, irritation, lacrimation, foreign body, but there is no pain. Secondly, remember, there is no fluorescein staining. The fluorescein staining of cornea occurs when you have an ulcer. Remember, fluorescein always stains the surface which is deprived of epithelium. So, there is no epithelium. So, in an ulcer, there is no epithelium. So, always it stains with fluorescein, but there is no staining. So, it cannot be an ulcer. So, absence of pain and the absence of the stain tells us it cannot be an ulcer. KCS with a person dry, but these are not the signs of redness, irritation. Yes, redness of dry eye, but irritation, lacrimation, foreign body sensation, they are not really symptoms of a dry eye. Is it not? Acute anti-uveitis, uveitis got nothing. With contact lens wear, there is nothing about uveitis here. So, the answer is the most common side effect of contact lens wear, or please remember, many of you have actually suffered from this, my students have. It is giant papillary conjunctivitis. This is the single most common complication of contact lens wear, where you get this huge papillae. Remember, normal papillae are less than 0.3 millimeters in size, less than 0.3 millimeters in size. These are more than 1 millimeter. Remember, the definition of giant papillae are papillae which are more than 1 millimeter in size. Look at the massive papillae, flat topped, reddish and velvety. This is the GPC, which is specific complication of anything in the eye which is a foreign body. Could be contact lenses, could be stitches left behind, could be a prosthesis, So, as the lid blinks, as you blink almost 8,000 times a day, so this lid, it hits the contact lens edge and creates these ulcers, not these ulcers, sorry, this papillae. Giant papillary conjunctivitis is the most common side effect or complication of contact lens wear, and we diagnose this because the absence of fluorescein staining and by the absence of the pain. Okay, then painful and loss of vision also, would have gone in favor of bacterial ulcer. So, remember, the fluorescein stain is very important for ulcers because it will only stain, kindly remember, whenever the epithelium is sloughed off. When the epithelium is intact, it will not stain, and let us take a look at that. This is how fluorescein stain appears. Remember the famous cobalt blue filter which I keep on telling you, that you see the stain with a specific filter which has been asked in the last year. They have been asking, at least 2 exams have asked this. Remember, the name of this filter is called cobalt blue. This is mounted on the slit lamp. So, we shift this filter and we can see this fluorescein staining with the cobalt blue filter. And this fluorescein stain, remember, is only seen whenever the epithelium is lost. So, in a corneal ulcer, when there's damage to the epithelium, you will get a staining, and you can see it in any kind of ulcer. You can see it in corneal abrasion, corneal epithelial defects. So, fluorescein staining will be definitely present in an ulcer. Okay, very well. So, the answer here we've got back again to GPC. Kindly remember, this is a very standard question, and you should not make a mistake with this. And you've got somebody answering this again, answering as a hydrophonium icepick test also, very good, that's correct. And most of you got the GPC right, and you've got, many of you have got this right. Okay, very well. Next question. Which sign is useful? Another, this is a very powerful question asked recently, in distinguishing between congenital and acquired forms of Horner syndrome. You all know Horner syndromes, which is oculosympathetic paralysis. Not Horner syndrome is oculosympathetic paralysis, where the sympathetic system of the eyes gets paralyzed by various causes. So, we have 2 different forms of Horners. From birth onwards, we call it congenital Horners, and acquired, which is called Horner syndrome. So, what is to distinguish them? And let us look at the choice. We have ptosis, lid drooping down, we have decreased facial sweating, we have heterochromia, and we have decreased dilatation with 10% cocaine. Okay, so, this is an interesting question which many of you should be able to answer. Let us look at that. Remember, Horner syndrome we memorize by OSP, and here, ladies and gentlemen, oculosympathetic paralysis. This is a tip for you how to memorize. You may find it often difficult to memorize the full word or the sentence, but if you make it a short form, abbreviation, you might find it easier. So, oculosympathetic paralysis we often memorize by OSP. Okay. So, this is the typical pathology. How do you diagnose it? They diagnose it by the famous mnemonic PMA. Okay. Ptosis, meiosis, and anhydrosis. Or not? P for ptosis, M for meiosis, which means pupil is constricted, and anhydrosis, which is pupil absence of sweating, because basically sympathetic system is one which helps for sweating. So, it is paralyzed, so there is no sweating. Okay. So, let us see how to distinguish between ptosis. Can anyone know? Both of the congenital and acquired have ptosis, so it cannot. Decreased facial sweating, again both of them have anhydrosis, though it is more difficult to find out, because all our air conditioned OPDs are air conditioned nowadays, so it is difficult to find out. Decreased dilatation. Remember, this is the test which works both ways. Cocaine is a very powerful test, and cocaine is one of the most powerful mydriatics. That means it dilates all the pupils except Horner syndrome. This is a very powerful test. When you want to confirm Horners, what you put is a drop of cocaine in both eyes, and the one that is normal will dilate immediately, but the eye with the Horner syndrome, it will not dilate with cocaine. That is the test. And decreased dilation with cocaine is the test for Horner syndrome. Remember, this is also seen in both of these conditions. The only thing that is not seen between the two and differentiates between congenital and acquired is the heterochromia. This is not heterochromia, means the two irises are differently colored. Can you remember, this is the answer. Heterochromia is the one feature that differentiates between congenital and acquired forms of Horner syndrome. Okay, and you can see it here. Look at that, marvelous. Look at the heterochromia, and this is the lighter colored iris. Always remember, it's the lighter iris which is seen in Horner's. So you can see. Can you see the ptosis compared to the eye? Look at the small pupil, meiosis, and hydrosis. You cannot make up in this picture. Obviously, it's difficult to make out, but you can see the terrific heterochromia. This tells, but why does heterochromia occur in congenital Horner's? Remember, the reason is, logic is, you see, remember the pigmentation of the iris is because of melanocytes. Okay, the melanocytes migrate to the iris and deposit pigment there, so it causes the pigmentation of the iris. But these melanocytes, remember, are under the control of the sympathetic system. So what happens? From birth onwards, the sympathetic system is paralyzed. So if the sympathetic system is paralyzed, so there is no release of the melanocytes. So there is no migration of the melanocytes to the iris, and they do not cause any pigmentation because the migration of the melanocytes is under the control of the sympathetic system, and that is paralyzed. So it goes to the opposite eye, but it does not go to the affected eye, and that's why always a lighter colored iris is the Horner syndrome, not the heavier colored. Okay, so the answer is, and I'm sure most of you got this correct, heterochromia. Most of you have got this correct. This is indeed the answer is C, and many of you got this correct. Yes, many of you got this right. Very good. Vipin has got this right, and so has Vipin has got this right before also. So let's look at the next question. So you all are doing very well, and I'm so proud of you, and I'm so good, so happy. A patient presents with painless loss of vision. Okay, so the painless loss of vision, anterior segment is normal, but on examination of the retina, the multiple punched out lesions were present. More difficult now. What is the most likely diagnosis? Okay, so basically what we've got here is a painless loss of vision, blurring of vision, anterior segment normal. So the only findings are in the retina, where we have these punched out lesions. What could be the cause? Myopia, toxoplasmosis, ankylosing spondylitis, or IH, idiopathic intracranial hypertension, where the pressure rise in the ICT causes papilledema, isn't it? Now, before we go to this question, first we need to know what is punched out lesion. You know, punch is not the punch which many of you would like to give to me unless I stop the class very fast. It's not that punch. The punch, you know, is that you're punching paper, no? So this is the punch, you know. So you take a punch like this, so it creates a clean cut, absolute edge like this. Absolutely clear. This is a punch. So whenever you get this word punched out lesion, remember in any question of medicine of MBBS or MD, it means a lesion which is clear cut, circumscribed, and absolutely clear, sharp margins. So this is what a punched out lesion, as if created with a punch like that. Okay. So of this, which do you think? It could be myopia? Incorrect. Myopia does not have any punched out lesions. Okay. Myopia causes enlargement of the eye, which may thin out the retina. So myopia it is not. Ankylosing spondylitis, remember, it causes anti-uveitis, and anti-uveitis would have anti-segment findings and plus the redness, so it cannot be that. Idiopathic hypertension causes papilledema because it is raised ICT causing disc edema. Again, we don't have punched out lesions, so by elimination, it becomes toxoplasmosis. Remember, toxoplasmosis is created by cats. Remember that? Many of you have pet cats in the house. Watch out for cats. No, kitty is very cute, but kitty can be very dangerous also, is it not? So toxoplasmosis comes from cats, and remember, it causes the posterior uveitis, is it not? Remember, the most common presentation of toxoplasmosis in the eye is posterior uveitis. Painless blurring of vision, which is why they come here, painless loss of vision, and we diagnose by the famous punched out lesions as a clean cut. You know, see what I mean. Look at the proximal scar here. Look at the clear cut, clean margins as if created with a punch like that, is it not? So this is how toxoplasmosis comes to us. Remember, from cats, cause posterior uveitis, and most of them, they can be congenital toxoplasmosis, could be acquired toxoplasmosis. This is acquired toxoplasmosis. Congenital toxoplasmosis. Remember, do you all remember the classic triad of congenital toxoplasmosis? No, you have raised ICT, tram track calcification, and you have one more thing, which you, the threes of congenital toxoplasmosis you must remember. So the answer here is toxoplasmosis. Difficult question, but one which you should learn about. Okay, very clear cut for the punched out lesion. That gives us the clue, like I created with the clear cut punch. Next. So I'm going to fast agent, trying to finish this before you fall asleep or unconscious, whichever comes earlier. So, a patient presents to the OPD, and here I need a sip of water, and many of you probably need coffee also. Patient presents to the OPD and complains of a gradually progressing painless loss of vision. So, slowly developing loss of vision. He describes his vision as like looking through a waterfall, or waxed paper, like a paper which is like waxed. Okay, very classic description. Ladies and gentlemen, if you haven't got this, I will be very upset. I will be very, very upset. What is the most probable diagnosis? Looking through a waterfall, like a waterfall, or through waxed paper. Let's look at the choices. Primary open angle glaucoma, retinal detachment, retrobulbar neuritis, and cataracts. Okay, so we have this multiple options here, and first of all, you see all of them here. We can rule, even if you do not know the answer, let's see how we can rule that out. Come to gradually progressing pain loss. So, all of them, as you can make out, except retrobulbar neuritis, is painless loss of vision. So, detachments, open angle glaucoma, cataracts, all are painless loss of vision mentioned, but retrobulbar neuritis is not. You all remember, retrobulbar neuritis is pain with ocular movements, remember, particularly when looking upwards or inwards. Okay, so it's painful ocular movement, so it cannot be that. Second is a gradually progressing. So, that rules out retinal detachment, because retinal detachment is a sudden painless loss of vision. Remember, this is gradually progressing painless. So, you got a choice of primary open angle glaucoma and cataracts. But since his vision is like seeing through a waterfall, so what is going to be? The answer is going to be a cataract, because remember, that is the word cataract comes from a waterfall, is not? See this lovely waterfall here. These are called cataracts. In the English language, a waterfall, a series of waterfalls is called a cataract. In fact, the word cataract comes from the waterfall. Okay, why? Because if you stood under a waterfall, your vision would be blurred vision. Okay, because you would see through the waterfall. So that is why cataracts are called cataracts, because it causes blurring of vision, and the blurring of vision is similar to the blurring of vision seen if you stood under a waterfall. So that is why an opacification of the lens is called a cataract, because resemblance to vision as if seen through a waterfall. And I am sure all of you got this correct. And let's see, yes, Vipin has got this correct, Nidhi has got this correct, and one more, somebody's got this correct. So cataracts it is. Very good. I'm so glad you're doing it. I thought it was a tough paper, but by judging by the answers that you all getting this is not so tough at all. Excellent. So we have got a cataract. So remember, waterfall, waxed paper. So sometimes we like to ask case questions based on the names and the origins of that. We can got that. What next? Let's talk about the next question. A 7-year-old child presents with complaints of poor vision in the right eye. Poor vision in the right eye. Small child. On vision 6/60, that's quite loss. That's a big loss. 6/60 is just the first line. And retinoscopy reveals a refractive error of +5. Okay, so it's a hypermetropic child. On wearing a correction, that means +5, the patient's vision remains 6/60. But why? If he is a refractive error patient and we've got +5, then why does the vision not improve? What is the diagnosis? Let's look at that. Hypermetropia, as I said. Congenital cataracts, well, possibly. Amblyopia and retinopathy of prematurity is a 7-year-old child. So, what do you think is the answer? The clue is hypermetropia. The answer is not hypermetropia. Why? Because if he had been hypermetropic, the vision would have improved, is not, but remains 6/60. It's still 6/60. So, it is not refractive error, isn't it? So, if because of refractive, he would have improved. So, could be congenital cataract? Yes, it could be, but unlikely here, because there is no clue provided here. What is the clue? Is there any clue provided? Why should a 7-year-old child? Is there any reflex which is leukocoria? No. Okay. Is there any sign where the mother comes to you and says, look, doctor, you can't see, like as we see is in a zonular cataract? Is there any spokes here? Are there any riders here? None at all. There is no clue here, so it can't be. What could be? Could be ROP? No, ROP does not present. There is no clue again. His vision comes to us at 7-year-old. So, if he had an ROP, he would got it at 7 months itself, is it not? So, answer, ladies and gentlemen, I am sure you got all this correct, is amblyopia, is it not? And because why? Because amblyopia by definition is a loss of vision which is not known to us, and a patient who comes to us who is loss of vision, but we don't know the cause, and who does not improve when we correct the underlying condition. That means if he has a squint, we correct the vision, correct the squint, there is no improvement of vision. If it is refractive error, he wears the glasses, there is no improvement in vision. So, that is the answer. In the definition itself, it is amblyopia because the vision is still 6/60. So, the patient is amblyopic. Okay, the answer is very correct, and it is answer C. And let me see how many of you got this right. And Nidhi's got this again right, and so has Dr. Virender. Many of you got this right. Okay, so answer C. And you know the treatment for amblyopia is occlusion. So, we close the good eye, is not? Remember, this is the amblyopic eye, and see, he's wearing glasses, not improving. So, we close the patch the good eye, so that we force the bad eye to develop fixation, because if we keep both eyes open, then he would never use the amblyopic eye, he would only use the good eye. So, we force the good eye shut, and so we force the bad eye to develop fixation on its own. Otherwise, left to themselves, they would never improve. Okay, so this is amblyopia indeed. Very good. What next? The next question is amblyopia after amblyopia. So, we are rapidly doing well, and I want to finish it as fast as possible, so that you can go back to your work. All of the following are seen in congenital glaucoma. Again, dear me, again, all of the except questions again are being asked. So, all of the following are seen in congenital glaucoma except. So, what is the except here? Let us look at that. Corneal edema is 1, myopia is 2nd, Vogt striae is 3rd, and optic disc cupping is 4th. Okay. So, we have these 4 choices. So, we talk about ophthalmos or congenital glaucoma. So, you see what happens, remember, in ophthalmos happens, there is a blockage of the angle by the Barkhan's membrane. So, the aqueous humor cannot get out, you all know. This is the angle, and it is blocked by this particular membrane, which is called the Barkhan's membrane, which is present as a congenital anomaly, is it not? So, it blocks this membrane, and it blocks the membrane, so the aqueous humor cannot get out, raise the intraocular pressure, cause a damage to the optic nerve, cause glaucoma. This is congenital glaucoma, is it not? So, we need to see which is there present, all except. So, will you have corneal edema? Yes, definitely. You will have corneal edema, because you see, because the raised intraocular pressure, it will rush into the cornea, is it not? So, normally the cornea has these endothelial cells which pumps the aqueous out, is it not? The endothelium cells, they pump the aqueous out. So, that is why the cornea is clear. But in this case, because the pressure is very high, because the blockage of the membrane here, so the aqueous humor, it raises. Pressure is often in the mid 30s, you know, around 30 to 35 millimeter intraocular pressure, then the mid 30s of these children, and so they rush into the cornea, causes corneal edema. They cause corneal edema, and they cannot be pumped out because the pressure is too high. So, there will be corneal edema, which causes the haziness of the eye, which is why these children are photophobic and blepharospasm. They cannot tolerate the eyes to light. Okay. So, this is seen. Would you see axial myopia? Yes, myopia also. Why? Because the eyeballs are large. Remember, these are very small eyes and they are highly elastic. So, with raised intraocular pressure, it stretches the cornea, the sclera, and the size of the eyeball enlarges, and you know that they will cause axial myopia. You also should remember that each 1 millimeter of extra length causes 3 diopters of power. So, they have large eyes, that is why they are called ophthalmos, and they will have myopia. It is also correct. And will you have optic disc cupping? Yes, they will have optic disc cupping. Remember, cupping always occurs because of raised intraocular pressure. It destroys the neuroretinal rim. So, rim destroys, the optic cup enlarges and advances to fill up the space. So, they will have cupping of the optics, which is the sign of glaucoma, one of the most important signs. So, you will have all 3, but what we want to see are all of this, but except what about the Vogt striae? And that is the answer, because remember, we do not see Vogt striae in congenital glaucoma, we see Hab striae. Is it not? They are both striae. Remember, there are 2 striae in ophthalmology. Striae means folds, and one is the famous Hab striae, which you see in ophthalmos. Look at that. The classic Hab striae, rupture of the Descemet's membrane, those lovely parallel railway tracks appearance. This is the famous Hab striae which you see in congenital glaucoma ophthalmos. But the answer is not Hab striae. In the choice we had Vogt striae. What on earth is that? Remember, Vogt striae are folds in the cornea, but in a different condition, not glaucoma. The condition is the keratoconus. Look at that. Can you see these vertical scratches? These vertical scratches that you can see here, as if somebody has scratched the cornea out, you know, these are called Vogt striae. V for Vogt, for verticals, they are seen in keratoconus. Okay, kindly remember, this is seen in keratoconus, but Hab striae are seen in ophthalmos. And that is the answer, because they substitute, instead of the Habs tri, they gave Vogt's tri, and all of them are seen except. So, Vogt's tri, answer choice for this is C, and many of you got this right. No, yes, you got this right. We've got Vrinder Soni again right this right. We've got this right. Very well. So wonderful, my friends. You're doing so well. I'm so proud of you. So it means that you've studied ophthalmology well. You see, ophthalmology you need to study well, because it's a powerful subject. It's short, not really short, but you can score well. For anything between 15 to 20, you can score by doing ophthalmology. Okay, and that is the trick here. You see, most of you get fooled about doing the longer subjects, the medicine, surgery, obs and gynae stuff. Remember, of 30 questions, you can never do, of the longer subjects, you can never do 30. You can maximum do 22, even if you study well. If you don't study, you will get 15, but you can. But these are general subjects, but often so specific. If you study a little bit, you get the full 15 to 20 questions. I keep on telling this, sometimes you listen, most times you don't listen. Very well. What about next? So we've got next question is, in which surgery? Now this is another very popular question been asked many times of recent years. And what is that? So we've got an instrument here, and this instrument here, what you see in this, what surgery is used, and look at the clue here. The clue here is that, see, this is flat surface, okay, and this is a ring shaped here, okay. There's the clue. Remember, there is another instrument which you will confuse often. It has two blades, but here one is a flat sort of a blade, the second is a ring kind of a thing, and this is a ring which gives the clue to the surgery. Let's look at the choice. We have enucleation. We will take out the eyeball. This is called enucleation. Second is chalazion. Okay. Third is entropion. You know entropion, where inward N, so it's inward rolling of the lid margin. Could be upper eyelid, could be lower eyelid. Okay, so inward rolling. And trichiasis. What is that? Trichiasis is the eyelash rubbing inwards. No. So we have this for enucleation surgery, where you take out the eyeball. You have chalazion. What is a chalazion? Chalazion is a painless, and it is non-tender swelling on the upper or the lower eyelid. It's because of blockage of the Bowman glands. And entropion is a inward rolling of the lid margins with the eyelash rubbing inside, and trichiasis is the eyelash rubbing inwards. Okay, so trichiasis. So the answer here, and I hope all have got this correct. If you look at the instrument again, the clue is in the ring. The answer, gentlemen, is going to be a chalazion. Okay, a chalazion it is, because the ring, it covers the, look at the clear. Can you see? Many of us, we have it. It's a very common affliction. Okay, particularly occurs to people with oily skins. So it's a recurrent chalazion where the Bowman glands get blocked and the secretions are not able to drain. So this is a non-tender, painless swelling seen in the upper, the lower lid, mostly in the upper, less in lower, because number of Bowman glands are slightly higher in the upper lid, and the chronic inflammatory granuloma of the Bowman glands. So what we do, we invert this lid, and the ring grasps, the ring circles the chalazion, and then we incise it like this. Remember, we call this IN, not D. It's not incision drainage. It's not pus. It's not. We call it INC. It's called curettage. So you just drain it. So you put this ring around this, and you invert the lid so that there's no scar, and you make this vertical incision like this. Okay, one vertical incision, so as not to cut the Bowman glands, and you scoop it out. These are often oily secretions. So this is called I and C. The treatment is incision and curettage. Remember, incision drainage is done in pus, in pustular conditions, but this is not pus. So this is the instrument. Kindly remember, often asked many times, it's the ring that tells us that it is a incision and curettage being done for chalazion clamp or chalazion forceps, we can call it. Very good. So I hope many of you got this right. Many of you got this right. Many of you got this right. That's absolutely right. What next? So next question is, after one chalazion is, now this is much more difficult, and I'm sorry for inflict, but nowadays they are trying to give you questions from NEET-PG. This is a very askable question. So you are shown a surgery here, and what surgery being seen. So what to see at the limbus, you see there's a cotton tip applicator, and this triangular incision is being, the flap is being created on the limbal part of the skull, is it not? So what is this? this flap, this deep incision being made, and let's look at the choices here: capsulorhexis and cataract surgery, scleral buckling in retinal detachments, trabeculectomy in glaucoma, and trephining in keratoplasty. So, trephines in keratoplasty, and if you've all seen this, most of you can see this. It's not a capsulorhexis. We do it with a single opening like this. This is capsulorhexis. This is so this is not rhexis. Scleral buckle, many of you have seen a silicon buckle which you place over the sclera. It encircles the sclera completely and pushes two retinas together. Detachment, this is not scleral buckling. Trephines for cutting the cornea and replacing for keratoplasty. This is the not a trephine. Again, you will see a trephine like this, but this is the typical trabeculectomy being performed. You see, in trabeculectomy, what we do, we take out a small piece of the trabecular meshwork and put the scleral flap, okay, over this. So, this is the scleral flap, which can be triangular, it can be rectangular, and we cut this flap on the sclera, and because nowadays these are partially filtering surgeries. So, this is how it looks like in a trabeculectomy surgery for glaucoma. Okay. So, this is the answer. I am sorry for giving a tough question, but this you should know, and look at that. So, this is the flap being raised. The flap, this is a rectangular flap here, and we go inside and cut a piece of the iris from it. This is the typical trabeculectomy, which is performed as the last step in glaucoma. You can do it in angle closure, you can do it in open angle glaucoma also. Okay. So, remember glaucoma treatment we had stepwise. First, we used to do drugs. Okay. If that failed, we go into argon laser trabeculoplasty, ALT, and third is trabeculectomy, is it not? So, this is the third stage. Trabeculectomy is very good surgery, and the problem is that there are too many complications. Okay. So, the problem is it's a difficult surgery and everybody cannot perform trabeculectomy. The chance it does cause immense load of intraocular pressure. The problem is that it can be accompanied by a host of side effects. So, trabeculectomies can be done only by people who are specialized for performing these surgeries. The answer is, ladies and gentlemen, again take a look at this, is called as trabeculectomy. This is how we perform it. Has anybody got this right? The choice that you have seen here is, answer is choice C, and my God, again when you've got this, Nidhi's got this right, and Dr. Virender has also got this right, Raj got this right also. Awesome. You guys are tremendous. I love you because, actually, I don't love you. I hate you because I don't like my questions to be answered so many. I really hate it. I have been a quiz master, so I hate my questions to be answered, but you guys are doing so well. What next? What have we got next? And I'm going to hurry up a little bit because we are, I don't want to remember. I want to make it short and sharp. So, we have this 75 lady complains of a gradually progressive, so remember the age of a lady who's gradually progressive blurring of vision. But remember, it's distance vision, it's only distance vision, but it's a paradoxical improvement of near vision. Dear me. So, this lady's distance vision is dropping, but near vision is improving. So, that's very nice. Okay, one, it's a composite of the other, and that gives you the clue. So, what is the probable diagnosis? This is a very important question, and you must get this, all of you. Open angle glaucoma, nuclear cataracts, cortical cataracts, and age-related macular degeneration. Okay. So, and the answer is, I hope you got this. Remember, the trick is to see that the distance vision is blurring and the near vision is improving. Okay. And this is a phenomena which is often seen, we call it as second sight. Okay. Kindly remember, the typical term for this is second sight. Why second sight? Because these are old people, they are 75, look at that. So, second sight is they have already lost their vision. Remember, they become presbyopic at 40, 45, is it not? So, at 45 years of age, all of us, we become presbyopic, is it not? And me, I am already getting presbyopic. So, this is presbyopic. We lose near vision because loss of accommodation. So, what happens is that after a certain age, when they have lost presbyopia, they have lost the near vision because of presbyopia, and many years later, 10, 20 years later, they get their vision back again. The near vision comes back. The near vision which they had lost at 45 due to presbyopia comes back again, improvement near vision, and that is why this is called a second sight. They have got their near vision back again, like a miracle second sight. Okay, and that is called second sight, and the blurring of distance vision and improvement near vision is seen in only one condition, in nuclear cataracts, is it not? The second sight phenomenon, remember, nuclear cataracts, look at that, you can see the amber color of the central nucleus, this is the nuclear cataracts. It causes loss of distance vision and improvement of near vision. Remember the famous triad of nuclear cataracts, 3 MCQs. First, they have hemeralopia, remember, hemeralopia, which is day blindness. They cannot see well in daytime, they can see in the night time. Second is that they have loss of distance vision. They have loss of distance vision because of myopia. So often this question can be asked, which type of cataract causes myopia, which is nuclear cataracts. And third, they have improvement of near vision, and which is called as second sight. So these are the 3 MCQs we'll have to ask in nuclear cataracts. So they have loss of distance vision, improvement of near vision, and hemeralopia, which is due to day blindness. But why should we have improved near vision? See why. This we need to understand, and sometimes it becomes a little more difficult to answer. So let's look at that. So this is a patient. Remember, this is say at about 45 years of age. So what about 45? The distance vision is fine. Okay, the focus on the retina like this. But at 45, the near vision, it starts to getting, because of loss of accommodation, not. Let me show you near, so we'll draw this in red. You know why near vision be lost? Because of preservation. Near vision, you know, anything that is near, rays are divergent, so they become parallel later, and when they become parallel later, so will focus later also, so they focus behind. So this is for near vision, this is for distance vision, okay. Now normally for near vision, we accommodate. So we accommodate, and that means increasing the power of the lens from the 16 diopters. From 19 diopter original lens, you add another 16 diopters, total making of 35. So because we can accommodate, so rays of light can focus on the retina. So young people, we have both distance and near vision good. But these are 45-year-olds and they have losing accommodation. So as they lose accommodation, they cannot increase the power of the lens to 16, and the near vision remains poor unless they wear glass. They wear the convex lenses which can focus on retina. So this is a 40-year-old. Now see what happens to this as they become 45, but now they are about 75. Okay, now look at that. So what is going to happen for 75-year-old or a 70-year-old when they develop a cataract? It becomes like this. Let's say now that we have a 75-year-old. So now they have developed a cataract. So there is a cataract here. Okay, so there is a cataract here, and this cataract, it causes index myopia. Why? Because it increases the refractive index. By compressing the nuclear fibers together, it increases the refractive index. So increase refractive index, so more rays will bend earlier. Because remember, the normal refractive index of the center of the lens is about 1.40. This is the refractive index of the normal lens. When it becomes cataractous, the refractive index may rise to 1.42. So because there is more bending, more refractive, so there is more bending of light. So see what happens. Because it bends more, so the distance rays bends more and comes earlier, and the patient develops myopia. See, remember, it comes earlier, and any rays that focus in front of retina we call myopia. So that's why the distance rays, they were on the retina and they come forward, so you become myopic. Patient becomes myopic in nuclear cataract. But the near vision also comes forward, no, because both this and near will move forward because of the index, refractive index being higher. So the near rays now come on the retina. So see what happens? The near rays improve and the distant rays becomes in front. So the patient becomes myopic for distance, but the near vision improves because the focus is right on the retina. This is called as second sight, and that is why these patients are famous for their improvement of nuclear cataracts causing improvement of near vision and worsening of distance vision. This is the famous second sight of nuclear cataracts, and only one condition, nuclear cataract, causes the second sight. So that's a very painful and a prolonged explanation of a very simple phenomenon. Very well. So I hope many have got this right. Oh dear me. So let me erase this all. Next question. A 50-year-old librarian presents with ocular irritation. Librarian with a lot of irritation in the eyes, not because she's reading books, and not pain. Okay, so remember this many of you complain of pain and irritation. Don't just dismiss it like, okay, it's nothing, nothing. There has to be something, okay? It's not all about imagination. So, pain and irritation, non-specific complaints, but very specific pathology. While applying makeup, she noticed that the eyelids appear to be different levels. So, one eyelid may be upper than below, no, at different levels. What could the cause be? So, remember, what are the clues here? The clues here are that eyelids appeared up different heights and that she has non-specific pain and irritation. There seem to be not enough clues to answer this question, but actually is enough. Actually is enough. Let's discuss why. Let's look at that. The choice we've got, one is called trachoma, one is rheumatoid arthritis, thyroid eye disease, and myasthenia gravis. Okay, so we have these 4 important ones. Let's look at that. Could be, let's take it one by one. Could it be myasthenia gravis? No, unlikely, because myasthenia gravis, there's nothing about getting exhausted at the end of the day. Remember, no fatigable ptosis, no fluctuating ptosis. So, myasthenia does not. Even though the age group is fine, age group is okay, but there is nothing of myasthenia. Could it be rheumatoid arthritis? Unlikely. Rheumatoid arthritis, what is the most common ocular side effect you all know or should know is severe dry eyes. Can you remember rheumatoid arthritis, the main and the most problematic ophthalmic manifestation of rheumatoid arthritis is keratoconjunctivitis sicca, KCS, dry eyes. There is nothing about except maybe irritation and pain which is telling us about rheumatoid arthritis. But what about the eyelids upper and low? That is the real clue, no? One above, one low. And trachoma, could be trachoma, unlikely, it is not trachoma. Again, trachoma, remember, they have not mentioned any seograin follicles, they have not mentioned watering or irritation or redness of the eyes, no discharge, not, no outlines, no Herbert-Spitz. So, the answer by exhaustion is rheumatoid. Thyroid eye disease, it is needed. Look at that, and everything falls into space. Non-specific pain irritation, remember, is a very specific. Actually, it's non-specific, but it is in thyroid. These patients are very wretched and they have a lot of pain and they do have a lot of irritation also. So, this is very much a sign of thyroid. But the trick is the eyelids, the one up, the other below at different levels. What is that? It's talking about the most common ocular manifestation of thyroid disease, which is not proptosis, I always keep telling you, but lid retraction. Look at that, very important. The one upper lid retracting behind, okay, this is normal, and this is the upper lid retraction occurring, which is the most common presentation of thyroid. Can you remember, all of you, I keep emphasizing this, that the commonest presentation of thyroid is not proptosis, that's second commonest. The commonest is lid retraction, the lid retracting behind because of the sympathetic overstimulation of the Mueller's muscle. Remember, because there's excessive thyroxine being pumped into the bloodstream. So, this stimulates the Mueller's muscle. It's a sympathetic plexus, remember. So, it is overacting, and this is why the overstimulation of the Mueller's muscle by the sympathetic stimulus, which is given by the thyroxine, lid retraction it is. And so, and remember, this is the 50-year-old lady, remember, thyroid is almost 5 times more common in women as compared to males. So, these are any women between 40 to 60, they have thyroid almost 5 times more common than males. So, the answer is thyroid is, I think many have got it, and if not, it's a wonderful question. So, what is the moral of the story? The moral of the story is that maybe we should all apply makeup. Ladies, at least a few, maybe you should all start applying makeup, because removing makeup or applying makeup makes you focus on the eyelids, is it not? Well, too bad I can't do it, and I can't do it, okay. There are enough layers in me already, I can't put any further layers. Very well. So, you've got a lid retraction. Have anybody got this correct? That means absolutely, we've got, the answer was C. So, we've got a lot of people, Virendra's got this right, we've got Nidhi getting this right. So, we have a lot of people getting this. Wonderful. Another important question. I like this question. Let's take a look at that. A patient presents with blurring of vision. Okay, naturally, ophthalmology, we have to face with blurring of vision. On investigation with an Amsler's grid, which you see here, Amsler's grid, okay, a grid, piece of paper with these squares there, and she draws a chart like the one. Look at that. With the grid, she's drawn the lines like this. This straggly, this irregular, non-parallel lines, as if the pen is struggling, she's struggling with the pen and running out of ink and the hands are trembling, something like that. But nothing of the kind, no, hand is not trembling at all. Where is the pathology located and what is the diagnosis? Simply by drawing these straggly irregular lines, curved lines on a piece of paper, we can diagnose the condition. Let's look at that. Is it a cataract in the crystalline lens, opaciform lens? Is it optic neuritis affecting the optic nerve? Is retinal detachment separating the retina, or is the cystoid macular edema attacking the macula? Ladies and gentlemen, take your choice. Look at that. This is the Amsler's grid, and what she's drawing is these irregular lines. We've asked her to trace out these lines, but instead of tracing those correctly, she's drawn these irregular straggly lines. This is the sign of metamorphopsia, is not? Remember, metamorphopsia. Metamorphopsia means this is distortion of shape, is not? Distortion of shape. So instead of seeing the world in straight lines, they're seen curved and irregular and wavy lines like this. Distortion of shape specifically is a very specific sign of macular pathology. Any macular pathology will have metamorphopsia, be it cystoid macular edema, be it CSR, or be it ARMD. So the answer, ladies and gentlemen, is macula. This is the CME, the metamorphopsia displayed by any pathology of the macula. Here we have only one pathology, and that is cystoid macular edema, and this is what you see. Look at that, it is CME indeed, and you can see the swelling which we've outlined with these white arrows. So this is the yellowish spot which you often see on looking at established macular edema. The swelling of the, remember, CME is the swelling of the macula in the outer plexiform layer. Please remember, OPL and not the IPL, which many of you are watching all the time. The outer plexiform layer is one of the 9 layers of the retina. Remember, there are 9 layers, neurosensory layers, and 10th is the retinal pigment epithelium, is it not? So in one of these 9 layers, there is swelling, which is, that's why it's called cystoid macular edema. Edema is swelling, cysts, small cysts are there. In which layer? In the outer plexiform layer. And because the macula is affected, anything that affects the macula, you'll have metamorphopsia, which is demonstrated by these irregular, wavy, curvaceous lines on the grid. I hope you've all got this. Let's take a look how many have got this. The answer is D here, ladies and gentlemen. D for, you have got OPL right, Vrinder, you're absolutely right. Cystoid macular edema. Vipin has got this right, Rao has got this right. Awesome, you guys are fantastic. Very good. What next? So the next condition that we have here is going to be, okay, we have to identify the arrangement. Take a look at these, and these are very obvious. These whitish. Look at these, parallel, longitudinal, glands like this, irregular kind of things. These are the glands, and they have been upper lid has been everted. So these are glands in the lid, upper lid. And let's look at the choice. Glands of Zeiss, or Zeiss as you call them, glands of Moll, accessory lacrimal glands, and Morbin glands. Okay, again, so Zeiss or Zeiss, I don't know why that's disappearing. Zeiss glands or Zeiss glands, Moll, accessory lacrimal, and Morbin glands. And I hope, ladies and gentlemen, you all got this. Look at these parallel, irregular glands. These coiled up glands looking like a club sandwich with 3 layers. The outermost layer being lipid, which is the oily layer secreted by the meibum. Why? So that it prevents evaporation. The second layer is the thickest layer, is the aqueous layer secreted by the lacrimal glands and the extralacrimal glands. And the innermost layer is the mucin layer, which is secreted by the goblet cells, which are located in the conjunctiva, is not? Which does what? Which causes stabilization of the tear film, is not? So here we have these 3 things, and these glands, these coiled up glands like these, like snakes, are the Morbin glands. And I hope you all look at that. This is how the Morbin glands actually look like, parallel, and these are glands like this, regularly arranged on the upper lid. And you see this is the second, these are pathological. This is a normal how, and these are places where they have dropped out. So in MGD, which you call Morbin gland disease, MGD, which is a broad term for many conditions affecting Morbin glands. You have this Morbin gland disease, where you can see some glands were dropped out. The irregular glands here, they should be like this, but they're like, these are diseased glands. This is the Morbin glands, and they secrete meibum, which prevents evaporation. Okay, that's an easy one. Was that? I think it's easy though. Very well. What we, and then we're coming slowly. We're coming to the end of the class, and I know that many of you are getting tired. We want to finish this up. Let's do that. So 60-year-old lady complains of severe boring ocular pain. Boring means not this boring class. Boring means like somebody is boring into it, is piercing into it. No? It's piercing. The word boring means you take a bore and you dig deep, okay, like a piercing pain. Okay, so boring where you may not have enough sunlight. We have plenty to spare in our country. Okay, and as in Delhi, we were roasting under the sunlight right now. So what is the problem? So remember, there are too many clues here. First, the severe pain, painful enough to wake you out of your sleep. Number one. Boring. Remember, the word boring is very characteristic. It's something is digging into your eye, piercing into your eye. Okay, sufficient to wake you up from sleep. Okay, and she has a violet. The congestion, there's redness of the eyes, but it is not the bright red. Remember, the color gives the clue. Whenever it is bright red, it means superficial vessels have got inflamed, like in conjunctivitis. Remember, conjunctivitis is always bright red. Okay. It's the violet bluish congestion means there's a deeper layer of congestion. So it is not going to be conjunctiva with the episclera. It's a slightly deeper layer which lies under the episclera, which is the sclera. Is it not? So, and the third clue is under direct sunlight was a more probable diagnosis. Let's look at that. Episcleritis, which I was mentioning, and uveitis, which also has red eyes. Conjunctivitis, I mentioned, and scleritis, which I mentioned. The answer is scleritis. You know why? Because conjunctivitis is a bright red color. It's not bright. It's ruled out. So now, second, remember, conjunctivitis is never painful. Conjunctivitis has foreign body sensation, irritation, watering, but not painful. Uveitis is also, it can be painful, but it is not bluish violet. And also, remember, the severe boring pain is not the sign of uveitis. Is painful. Uveitis can be painful, but it's not so severely severe. And the bluish typical congestion, it is more of a pinkish variety. Okay, so the answer, and episcleritis is not. The episcleritis is too superficial. It is not very painful, and it is not at all. It is a bright red color again. In a sectorial congestion, the answer, ladies and gentlemen, very important for us, is scleritis, inflammation of the sclera. And look at that. Can you all see? You see the inflamed sclera. Look at the. If you look at this carefully, it's not a bright red color. Look at this carefully. Okay. This is not a bright red color. It's definitely bluish tinge around there. Remember, this is a picture under a slit lamp, so it is not that evident. But if you take her out in the sunlight, that's the trick. Whenever you suspect scleritis, we take her out in the sun and look at it. Then gives this bluish tinge, which is a sign that the deeper vessels have got inflamed. Deeper means under the conjunctiva, under the episclera lies the sclera. It is not. So this is a sign of scleritis. One of the most painful conditions in the eye. Remember, ophthalmology, there are certain pains that are very painful. One is acanthamoeba keratitis. Remember, pain out of proportion. One is scleritis, enough to wake you out from your dreams. Okay, so all of you lying asleep at night, dreaming of your prince charming or your princess charming, and you wake out of those shattered dreams, as I'm shattering many of yours today. Because of the pain, it's scleritis, inflammation of the sclera. Remember, these are often mostly older women. Okay, these are women mostly. And scleritis, also remember, the important point is that usually they have some systemic association. There are some systemic disorders with them, the most common being rheumatoid arthritis. Can you remember? This is also MCQ. Which is the most common systemic disorder associated with scleritis? Rheumatoid arthritis. Though it can be others like Wegener's granulomatosis. Nowadays we call it GPA, is it not? It can be other conditions also, scleroderma, it could be SLE, but the commonest systemic disorder associated with scleritis is rheumatoid arthritis. Can you remember that? So these are older women and very painful. The on examination of bluish violet, best visible sunlight. The severe pain is the sign, and the bluish violet tinge that you have should give it away. Scleritis. I hope many of you got this. The answer here is choice D. And how many? Wow, many of you. Rao has got this right. Vipin has got this right. And Medico says Dawn, sir. Ladies and gentlemen, the Dawn is right. The Dawn is here. And I'm so glad to see you and interact with you. Okay. Scleritis, Virendra has got this right also. I can't tell you how, whenever I know it's night time and that you people are tired and exhausted and would want to shut up, but I can't tell you how nice it is to interact with you, even on YouTube, and though I can't see you. Very well. What next? We have next question. All are seen pathological myopia. Now that's an important question. Let's look at that. All are seen pathological myopia except, okay. So myopia and pathological myopia. Remember, simple myopia is different, that many of you are. Pathological myopia is different because that is seen, mostly you have a lot of posterior segment signs. Posterior segment means mostly the retinal. So, this is not a simple myopia, this is pathological myopia. Temporal crescent, Foster-Fuchs spot, posterior staphyloma and antistaphyloma. So, this is an important question because it gives us three findings which are seen in pathological myopia or high myopia, but one finding is not. Okay. So, let us look at the answer, and here look at that, antistaphyloma is the answer. Okay. That's the, let's get this out of the way. What is that? You know, staphyloma, the word staphyle comes from grapes. Okay. So, this word staphyloma definition is a protrusion of the sclera, protrusion or outpouching of the sclera with involvement of the uvea. Okay. So, what you see is, if you look at the finding, remember, so this is the outermost layer, corneal sclera limbus. Okay. You all remember the diagram. The second layer is the uvea. Okay. The second layer is like this, uvea, and the third layer is the retina, isn't it, which I am drawing with blue. So, this is the three layers of the eye. So, what happens for various reasons? What is the staphyloma defined as? Outpouching, that means the protrusion of the sclera, say somewhere here. So, the sclera comes out like this, you know, it comes out, protrudes out like this, but a part of the uvea is involved in this. So, you will see a part of the iris, ciliary body choroid. So, this you will often see. So, this is a protrusion of the sclera with, you can see the dark area of the iris or the ciliary body or the choroid that comes out. This is the definition of a staphyloma. It is called staphyloma because it looks like grapes. So, staphyloma is a protrusion or ectasia or a protrusion or ectasia of the sclera with incarceration or involvement of the iris mostly. Okay. So, this is called staphyloma. So, antistaphyloma, for instance. And what happens? Staphyloma, there are 5 different kinds. You have anterior, you have posterior, you have ciliary, equatorial, you have intercalated. Okay, intercalary. So, the anterior staphyloma is a bulging of the sclera, bulging or protrusion of the sclera. Look at that. Can you see? Look at it. This is the bulging of the sclera that you see, but you can see the darkish color. This is the uvea, the iris along with it, because iris is trapped in the bulging. But this is called antistaphyloma. This can be seen in glaucoma. It can be seen in any inflammatory disorder. It can be seen in any infectious disorder. Okay. So, these are multiple causes. Post-trauma, you can see post-trauma, but particularly seen in end-stage glaucoma. This is antistaphyloma. Now, this is not seen in myopia. So, the answer is this one. So, we will talk about the rest of them slowly. The answer is antistaphyloma because we see they are not, the question is, it is seen, not seen where? It is not seen in myopia, it is not seen. It can be seen in glaucoma, trauma, you have corneal ulcers, perfect corneal ulcers, end stage glaucoma, you know, inflammation, but not myopia. So, these three are seen in myopia, and that is an important question because we want you to remember these three findings. Temporal, what is that? Temporal crescent is towards at the end of the temporal side of the retina, you will see a crescent shaped figure like this. This is called temporal crescent because the pulling of the retina, remember the eyeball is getting pulled because of myopia. So, stretching of the eye, it causes a temporal, on the crescent's temporal side of the disc, you will see a crescent like that. A very important sign is a Foster-Fuchs, remember. So, remember you have this in ophthalmology, we have this Dalen-Fuchs also. Some of you might remember Dalen-Fuchs spots is found in sympathetic ophthalmology, is not Dalen-Fuchs, but this is Foster-Fuchs. You can have many Fuchs, not. So, Shashwat ray and Lisa ray are not the same, is it not? So, let us look at that. This is antistaphyloma. Look at the Foster-Fuchs spot. See, it is Foster. As they bleed over the macula, this is macular hemorrhage. This is called as Foster-Fuchs spots. Please remember this, Foster-Fuchs. This is seen in high myopia or pathological myopia. And one more is the posterior staphyloma. Posterior staphyloma occurs where? Not in anterior, but in the posterior part of the retina. See, I told you that the its eyeball is stretching, you know, it's myopia. So, what happens is because being stretched, so the sclera becomes weak here and the retina, it bulges out like this because the weakened sclera, because of the thinness of the sclera, because remember it's a big eyeball. So, sclera becomes thinned out and the retina, it bulges out like this. Again, there is a bulge of the sclera with the retina incarcerated. This is a posterior staphyloma. So, this is a very dangerous sign of myopia, particularly you can see the posterior staphyloma, and this is the disc. You see, look at this area, this is the bulging out area, very good picture actually, you do not see it so clearly normally. This is the posterior half of the retina bulging out because of the thinned out sclera and the retina bulging out included inside the ectasia. So this is a very important sign of pathological myopia. So kindly remember, we have these three important signs of myopia. All of them are seen: temporal crescents, foster fuchs, piscivoloma. But anterior stavilloma is not a sign of myopia. Okay, it's seen in glaucoma, inflammation, trauma, and end stage eyes. So this is the answer, and I hope you've learned something new. Even if you may not have answered the question, I hope you've learned something new, and that's what is actually important. Now, this is now here comes an important question. What is the which of the following prescriptions is an example of simple myopic astigmatism? Simple myopic. Remember, I told you you should have one minus sign. That's called simple myopic. Compound myopic will have two minus signs. Simple hypermetropic will have one plus sign. Compound hypermetropic will have two plus signs. Okay, so let's look at that. We have -2 with a -3 at 90, -3 with a +4 at 180, +5 at 35 is another, and -3 with a +3 at 90. Okay, so now look at that. We want to know a simple myopic astigmatism. Remember, simple myopic astigmatism just means that is astigmatism. So you'll have two foci, is it not? You'll have two foci, but one will be on the retina like this, and one will be in front of the retina, is it not? So you see myopia as well as astigmatism. This is called a simple myopic astigmatism. So let's look at that. Now we remember that an example of simple myopic is that you have one minus sign. It will be like this: -2 diopter cylinder at 90 degrees. See, this is an example of a simple myopia. Why? Why -2? Because it's myopia, so you'll have a minus. Why cylinder? Because it's astigmatic, so you'll have a cylinder. Why 90? I can take any axis, anything between 1 to 180, right? So this is how simple myopia will look like. You'll have one minus sign with one cylinder and at a particular axis. This axis may be anything from 1 to 80 degree. Okay, so this is how it looks like. But the problem is that none of the prescriptions given to us look like this. Look at that. There are two minus signs. This is -2 with a -3 at 90. This is compound myopic astigmatism because there are two minus signs. What is that? Compound myopic means that there are two foci. None of them are on the retina. Both of them are in front. A simple myopia, one on the retina, one in front. Okay, this is compound myopia, both of them not on the retina. So this is not the answer. -3 with a +4, you have a one minus sign, one plus sign. This is called as mixed astigmatism. Some of you might remember. What is that? Mixed astigmatism means a condition where one of the rays is in front of the retina, the other behind the retina. Okay, mixed. So one is myopic, the other is hypermetropic. You can see that one is myopic, the other is hypermetropic. So this is a mixer. So this is also not the answer. +5 diopter at 9. Now this is a simple hypermetropic astigmatism. Why? +5 because my hypermetropia, cylinder, astigmatic, 35 any axis. So simple hypermetropia would like this. So one on the retina and one behind, isn't it? So you have two axes, and there are two plus signs. One minus one plus, is not. But you see they're equal. And so this is an example of a simple myopia because this is a very important question because here I'm going to teach you something called transpositions. Okay, transposition. Okay, remember. So what happens? Transposition means when you place a prescription in front of a mirror. Okay, so remember when I stand in front of the mirror, I am still an ugly old guy in front of the mirror. Okay, I do not become Disha Patani. Is not. Okay. So a mirror image is what? It's inverted, but it's the same thing. So putting a transposition means that if you place this prescription in front of a mirror, it would look different because my left would become right, right becomes left. But it's still me, is it not? I do not become Aishwarya Rai, right? So transposition, I'm going to tell you the trick of transposing a prescription which look different. The left looks right, right becomes left, but the prescription is the same. It's a very important rule. Ladies and gentlemen, let me introduce transpositions to you. Let me introduce transpositions to you. A prescription placed in front of a mirror. Look at that. Okay. So this lady is admiring herself in the mirror, and well, she might admire herself. She looks quite admirable. So this is she's standing in front of the mirror. So this is transposition. But so what are the rules of transposition? Look, first we reverse the sign of the cylinder. Rule number 1. Whatever the cylinder, if it's minus, make it plus. If it's plus, make it minus. Second, we change the axis by 90 degree. That means if it's 90, make it 180. If it's 20, it make it 110. If it's 180, make it, basically change the axis by 90 degree. And third, algebraically add the sphere and the cylinder. This is such an important rule, I cannot tell you. These three is how to make a, if we place a in front of the mirror, remember it looks different because the left becomes right, right becomes left, but the mirror image is the same. It's not, the person does not change. Let's do this. So, let me give an example of, let us say, minus 2 diopter sphere with a minus 3 cylinder at 90. Okay, you can all see, as I explained, we have two minus signs here. So, it is a compound myopic astigmatism, not. So, it is compound myopic astigmatism. Now, let me transpose this. Remember, transposing means that I place this prescription in front of a mirror. So, it will look different, but it is the same transcription, it is the same prescription. Let us look at that. Let us reverse the sign of cylinder. So, it was minus, it becomes plus. The 3 remains 3. So, we have reversed the sign. Minus becomes plus, plus becomes minus. Second, change the axis by 90 degree. This is 90. So, change it, it becomes 180. Change it to axis. So, that is. And third is algebraic summation of the, look at algebraic, that means keeping the signs in order. So, add the sphere and the cylinder. What is that? This is minus 2, this is minus 3, it becomes minus 2, minus 3 becomes minus 5. Look at that. So, this is the new prescription. Let me tell you, they look different, but they are the same prescriptions. They look different, but the same. Why? Because if you give this one, the patient would read 6-6. If you give this one, the patient would read 6-6. Why? Because they are actually the same. They just look different because we have transposed them, like in standing in front of a mirror. Again, plus becomes minus, by then becomes plus. If you transpose this, you get this. If you transpose this, you get this. Cylinder becomes 3, becomes 3. Change the axis by 90. That means 90 becomes 180. If you want to transpose this, 180 becomes 90 again. Okay, remember, I didn't say add it, I said change it. So, 180 plus 90 becomes 270. There is no axis called 270. You have to minus it here. And add them. Minus 3 and minus 2 minus 5. Add this. Plus 3 minus 5 becomes minus. If you change this, it becomes this. If you change this, it becomes this. Isn't it? So, can you remember these rules of transposition? And if we know the rules now, so now we can answer, the answer here is actually D. Okay. Let us see. Let me just erase all this. Okay, let us take this one. So, let us transpose this. So, this plus 3 becomes minus 3. Remember, change the sign of the cylinder. Second, change the axis by 90. 90 becomes 180. And algebraic, so plus 3 minus 3 becomes 0. So, see, minus 3 cylinder at 180, and is this not a simple myopic astigmatism? Remember, I said simple myopic astigmatism has to be one minus sign, because this is the definition of simple myopic, one on the retina, one in front. So, this is the transposed version of a simple myopic astigmatism. It looks different because you have 1 plus 1 minus, that fools you. Whenever you try to get fooled like that, apply the rules of transposition. Change the sign of the cylinder, change the axis by 90, add them together, and you get a new prescription which looks different, but it is this old prescription. It is the same old wine in a new bottle. Okay. Let me do one last turn, and then we'll. This takes too much time. So, again, let us transpose this particular thing, shall we? So, minus 3 becomes plus 3 cylinder, the 90 becomes 180, and minus 2 minus 3 becomes minus 5. So, this is a transposed version of this one. Remember, patient will be equally comfortable 6-6 with this and 6-6 with this. They are the same prescription, whether you write this one or it doesn't matter. Patient will get equal benefit from both. So, this is a very important rule. They look different because, as I said again, when I stand in front of the mirror, I still get to see an ugly old guy. I don't get to see the duckling, ugly duckling remains the ugly duckling. I don't get to see a swan when I stand in front of the mirror, which is why I avoid standing in front of the mirror. Very well. I hope you've got this. And ladies and gentlemen, have you understood this a little bit? Have you got some of the answers here? We've got a 4 answer here. Good. And here we really must speed it up now. It's getting a little late, but I don't want to delay you. So, let us do this fast, some of these. Okay. Identify the object. So, look at this carefully. Look at this carefully. This weird thing looks like a Ashok pillar or something, you know, which is inserted into this, and you can see that in more detail how it's inserted into here, whatever it looks like. What does it look like? Okay. And let's look at, is it an Ozurdex implant? Ozurdex is a dexamethasone implant which we do. It's a steroid implant in the eye. Ahmed glaucoma valve. This is a valve which we use, as you can see, in glaucoma. It's one of the aqueous drainage devices. Express implant. Again, as you can make out, this is a old AIMS question, not too old either. Express implant is another like glaucoma valve. This is one of the latest, in fact. This is for used for glaucoma, and it's a metal steel plant which is used for treatment of the it's a glaucoma drainage device, or it's a punctal plug. And if you look at this carefully, you will this looks difficult, but you can answer. As you can see, it is indeed a punctal plug. See what is it doing? Putting a plug. It is the lower punctum and the upper punctum. See the focus in the lower punctum. So you put a plug. It's made of either silicon or collagen, and you put it in the lower punctum. It looks like this, so it blocks it. But why would you plug the punctum? In dry eyes, in severe dry eyes, in cases or dry eyes, see what happens? There is not enough secretion of the tears. So what we do? We close the punctum, so that whatever tears are being produced, very little tears are being produced, they do not drain out. Okay, so it's like, you know, when you don't have sufficient water in a sink to wash your utensils, what do? You plug the hole in the sink so that the water remains there and we can wash our dirty utensils in there. So this is the same principle. We plug the punctum so the tears do not drain out and they stay here. So this is often done in moderate to severe dryness when adding lubricants is not helping anymore. Okay, it's not enough, because so the tears will not drain out again, and whatever little dry eyes, whatever little tears are being secreted, they stay in the eye. They do not drain out into the nose. Okay, so that was a punctal plug indeed. So new concepts, new techniques, new knowledge. This instrument can be used in all except. Okay, so we'll look at that. What is that? First, you have to identify the instrument. What is that? You see this metal thing, it's completely opaque here also, with a slit down the center. This is the stenopic slit. Ladies and gentlemen, you identified this correctly, I'm sure. The stenopic slit. But what is the use of stenopic slit? Let's look at that. Okay, detecting axis of the cylinder in refractive errors, corneal tattooing, Finchem's test, and optical iridectomy. Okay, look at that. What is this? Again, so this is used in all except. So can I use it in detection of axis cylinder and refractive? See, all of us remember the Finchem's test. This is definitely, you remember. So Finchem's test is a colored halo like this, correct? It's a colored halo like this, and so we do it into test whether the colored halos of cataract or an acute angle closure glaucoma. Is not both. Only he can see through the slit. As rotate this in the trial frame, at a particular point the patient says, I can see clearly, and that is this axis. That is a good way to detect the axis. I do it very commonly sometimes when I am not able to find the axis. So this is also correct. And optical iridectomy, what is that? Optical iridectomy means that suppose a patient has opacity, you know, and he is not able to see through that. So then we make a small hole in the iris. This is called iridectomy, remember, cutting of the iris, and this allows the patient a small amount of pupil through which he can look at that. What I mean is this one. Look at that. You see corneal opacity here, isn't it? Corneal. So this is the cell corneal opacity. So what we have done, the pupil is being blocked by the corneal opacity. It's right in the center. So what we create a small hole in the iris. This is called iridectomy, because you've cut the iris, the pupil, and by extending the pupil, so now the patient has some area, clear area of the cornea through which he can see. Previously the pupil was right behind the opacity, so he could not see it. So what we've done, we've created an extension of the pupil like this. Is called an optical iridectomy, so that he can see through this particular clear area of the cornea. Okay, and this is done by using a Finchem's. Why? We rotate the Finchem's slit in front, you know, and like this, and a particular axis, when the patient says, I see clearly at this particular axis, then we create the iridectomy. So in this case, we take a Finchem's test like this, and we rotate this in front of the eye, and as it rotates like this, the patient must have said at this particular area, he must have said that I see this clearly, and this we make a cut here. This is optical iridectomy. So we use this also. What we do not use it, and that is the question, is when we don't, what is not used in all except is corneal tattooing. What is that? When you get a opacity in the cornea which is white and it looks very ugly and the patient cannot see. So, we tattoo it, like many of you wear tattoos of your boyfriends and girlfriends on your arm, and many other places which I may not mention. Okay. So, we put a tattoo on that. We put a tattoo, we put a pigment on it, black color pigment to hide it. Look at that. You can see the corneal opacity here, it looks very ugly. So, this is pigmented, it is black in color. So, it looks, you cannot see through this of course, we just put tattoo on it, pigment on it. So, to hide the ugly whiteness of this. So, it does not have any vision, but at least looks normal. From a distance you can't make out. This is called corneal tattooing. This has no role in a corneal tattooing, it does not have a role with a stenopic slit. So, that is the answer. In tattooing, we do not require stenopic slit. Finchem's test we do, iridectomy we do, and refracting a cylinder we do. We require a slit in all of this, but we do not require it in what we do not require it is in corneal tattooing. It's a difficult question, I'm sorry to say that, but we must learn new stuff. Okay, has anybody got this right? Somebody, I'm sure somebody's got this right. Transposition rules, you're still stuck on transposition, not right. What next? So, you got this very important, and this is, ladies and gentlemen, was the last question. I must leave you now. Much as I hate, it's been wonderful interacting with you, but time is up, time is fleeting, and fleeting time. So, we have this investigation. The last MCQ of here is the, look at that photograph here. So, there is some spikes on the computer here. You can see this on the LCD screen, and you put something on the eye which looks like a probe which is on the cornea, and the patient seems to be quite comfortable because he is anesthetized. Okay, you cannot obviously put something on the eye without being anesthetized. So, what is investigation is being performed? That's a good question. I want you to see this. And is it pachymetry? Remember corneal thickness, is it that? Is it biometry? Is it tonometry? Or is it keratometry? Is it not? 4 things. So, let us look at these one by one. Keratometry, remember, kerato means cornea and keratometry means cornea. So, it measures corneal curvature, and this is not keratometry. Okay, this is not keratometry. Keratometry you don't do like this, you don't make the patient lie down. Keratometry is done with the patient sitting up with a keratometer. Is it tonometry? Intraocular pressure. Remember, tonometry, we have all heard about the Goldman apparition tonometry. This is not tonometry, it is not lying down unless of course Schiot's tonometry. Tonometry, you make the patient sit up on a slit lamp and you take a probe and touch the cornea, remember? Goldman apparition tonometry, this is tonometry. That is tonometry, intraocular pressure measurement, tono. Pachymetry, corneal thickness. How much is the thickness of the cornea? Remember, normal corneal thickness varies between 500 to 600 microns with an average of 540 microns, and this measures corneal pachymetry. This is not pachymetry. In pachymetry, you have to take a probe which looks like a pen shape and touches the cornea, and its ultrasonic probe measures the thickness. What is the answer? Is biometry. Okay, biometry, remember, is do not confuse biometrics. It's not biometrics where you put your fingerprints. That's biometrics. Okay, which we do in when you go for applying for visas, which you go for, for particularly identifying yourself. Biometry is a technique for calculating the IOL power, intraocular power. Whenever you, for a cataract surgery, see this probe put on the cornea like this, and for IOL power calculation for cataracts. Remember, in cataract surgery, you have to calculate the IOL power and you have to predict the IOL power, isn't it? So, how do you calculate that? That's called biometry. Also, it's called as a scan. Okay, this is an ultrasonic instrument. That is the a scan, A for amplitude. Okay, ultrasonic instrument, biometry, and it requires 2 important things. One is keratometry, which is the corneal curvature. Second is the axial length. So, remember, every time if anybody gets cataract surgery done, as many of your parents and grandparents have got it done, the first thing before we do cataract surgery is to calculate the IOL power. Because remember, we have to replace the cataract with the correct IOL power, is it not? And if you do the wrong calculation, what will happen? If you do wrong, we have to place the correct IOL because the rays of light have to focus on the retina. So, suppose you want a 20 diopter IOL, this is a normal, is it not? But by mistake, suppose you have put a 25 diopter IOL, is it not? By a wrong calculation. So, a 25 diopter IOL is more powerful and the rays would focus in front of the retina. The rays would focus in front of the retina, patient is not going to be able to see anything for distance because he's become myopic. And remember, you have removed the cataract, so he has no accommodation, right? So he has no near vision, and because you put the wrong IL power, he has no distance vision also. So he'll get very angry. So what have you operated me for? Neither can I see near, I have loss of accommodation, neither I can see distance because you have calculated the wrong IL. So for cataracts, we have to always calculate the IL power correctly, so the rays of light focus right on the retina. Okay. So this is a very sensitive examination, and we are always have to be very, very careful about it. So it requires, for biometry, we require two important variables. For every patient, we have to calculate. First, the keratometry, the corneal curvature. Second, the axial length. It varies, People have axial length. Remember, normal standard axial length is 24 millimeter, but it can be 23, 22, 21, 25, isn't it? So we have to calculate individually for every patient who undergoes cataract surgery. We have to axial length first, keratometry, put them in the biometric formula, and then the biometer calculates the IL power, which you see here. Look at these spikes here, they are showing us the perfect spikes. So this means we're calculating the axial length here. So biometry is for calculating the IL power before doing cataract surgery. Okay, and this is what is biometry. And with that, ladies and gentlemen, I have to say goodbye to you. This is the end of a tough class of 2 hours duration at least. And with that, all the for Medway we have, let me wish you all the best for the upcoming exams. And if you have any questions, please ask me. I'm waiting for you. And if you have any, we are still stuck on transmission. And Don sir, yes, my friends. So ladies and gentlemen, I don't want to take further of your time. And I hope you have a wonderful exam. By the way you've been answering my questions, you've already started very well. Okay, you've done very well. And it remains my privilege to wish you the best of luck in the coming exams. Okay, thank you very much. God bless you, and may you all pass the exam with flying colors. Thank you very much, and good night.